Right, good morning, everybody. Welcome to the KGH Public Board meeting. You're all very welcome. We're starting off this morning, as we always do, with either a patient or a staff story. In this case, it's a staff story. We're talking about the vaccination campaign, in particular the one within the hospital, rather than the one taking place across the county. So I'm going to turn to Paula, who hopefully is there. Yes, and I think Paula is going to introduce Alice, and we can have a presentation on how that's worked and the successes and the difficult areas that staff overcame to deliver this quite remarkable performance, really. Paula.
Good morning. Can you see me? Because I can't see that you can.
I can't see you.
And I cannot work out for the life of me how to fix that. I'm really sorry.
Well, you just keep talking and we'll work it out.
Okay, thank you. So it's my pleasure to introduce this part of this morning's session to you. Leading the vaccine programme for Kettering was an absolute privilege for me and one of the most exciting and impactful things that I've had the pleasure of doing during my career. I think, you know, it's very true to say that the NHS are full of amazing, dedicated people who come together and do amazing things, particularly at times of great need. And this was absolutely one of those opportunities and things that we did together. It was a truly collaborative event, and the system really came into its own. Certainly I, as the lead for Kettering, had amazing support from my system partners, particularly from Chris and Rachel at NGH, Chris, who leads the vaccine for the county, and Rachel, who's our lead pharmacist, colleagues in social care, NHFT, EMAS. It really was a true team event. And it was also an occasion where lots of people in Kettering really stepped up and gave of their best. And I'm delighted to ask Alice to present to you today, because Alice is absolutely somebody who did that for us. Just a little bit of background about Alice. Alice joined Kettering a couple of years ago and came as a temporary member of staff working in the charity team. She was the person who put together the Ned Story video, which you may have seen, which was our flu campaign. Alice then was spotted for her amazing video skills, and during COVID and our need to do much more engagement via digital means, she really came into her own. We then asked her to come and help us do some work with the vaccine, which started on a Friday night, which she'll tell you about in a minute. And gradually she stepped up and kept doing more until she was leading the vaccine delivery service in the rec hall in the second phase of delivering the second jabs. So I'd like to hand over to Alice, and she will tell you our story.
Thank you, Paula. That was lovely. So my name is Alice, as Paula said. I'm now the Organisational Development and Digital Learning Officer for KGH. And it was a massive privilege to be part of this project at the beginning of the year. And it's a real privilege to tell you about it as well. If I can have the next slide, please. So conversations about this one started way back in October. We were kind of talking about it. Might it happen? Might it not happen? And first official meetings about it started in November. When Paula was leading on these meetings, we were talking about it in a very hypothetical way. It was very clear from people, they were saying that we would never get the vaccine. It was very unlikely that it would come anywhere near us. If it was going to come near us, it would go to NGH and we would support them with that. And it would not be something that we would do. But we still kept talking about it just in case, because we could see internationally that it was heading towards the UK and that we were likely to be one of the first to get it. So we wanted to be ready. And the next slide, please. And then Northampton got it, and that was really exciting. We were so excited for our colleagues over there. And at the same time, we sent out our expression of interest form within KGH to find out whether our staff would actually be interested in having the vaccine. It was getting a lot of bad press at the time, and we really weren't sure whether our staff would want it. And the overwhelming response we got was that, yes, they would definitely want it, and they wanted it right now. So we started preparing for the fact that they did want it and who would be likely to get it first, because of the way the government was looking at cohorts, especially in those early days. It was very strict about who could go first. Our shielding staff were obviously quite high up on that list because they were some of our clinically extremely vulnerable. So we wanted to be ready for that. HR worked really hard on getting that together. And then one it was a Thursday afternoon in December, we got the notification from NGH that they were going to allot a certain amount of slots for our staff at their vaccine programme, which was so exciting. So myself and Paula and Andrew and a couple of other HR members of staff sat in a tiny little office and started making those phone calls. And it was amazing. I think it's one of my favourite memories of the whole process was those initial phone calls. Because people were so excited. It was the first glimmer of hope they'd had in so long. We were calling a lot of our shielding staff who had been scared for so long about, you know, what this virus might do, and it was a real privilege to be part of those early phone calls. More and more slots over the weeks afterwards became available, and we started putting more and more of our staff through. And then all of a sudden, we got notification that it was coming to KGH, even though they'd said it wasn't coming, it was coming. The fabled Pfizer was coming towards us at an alarming rate, and we had 10 days to set up and be ready for its arrival. And helpfully, that was 3 days before Christmas Eve. So in the 10 days that we actually had like 100 bank holiday days. So it was quite a quick turnaround to get that ready. The team making phone calls from HR were worked all through that period of time. And once the vaccine was actually going to be based, we were going to get a supply for KGH, that really was amplified because we were going to get about 1,000 vaccines per box, and making 1,000 calls to get those people in was not very pragmatic. We were making around 130 to 150 phone calls a day alongside our normal day jobs, and it was becoming very apparent that that was not going to work, that we needed a dedicated team for booking onto this programme. And it was the first time I think we'd all felt the immense pressure of making sure that we didn't waste any of these vaccines. And by making those phone calls, it wasn't going to work very well. Next slide, please. Thank you. So just, I mean, there was so many people involved with this programme. To get it actually set up for the first day, it took all of those departments, but I mean tens of people within those departments as well. There was so many people involved. They all came at it with their different specialisms. They all had a different thing that they needed to think about, and it all needed to come together at exactly the right moment. And it took a huge amount of work. So they are just some of the departments that were involved. I think there was a couple more, but it's really difficult because I don't think there was anybody that it didn't touch. You know, everybody had some kind of input. Thank you. So then it arrived. Next slide, please. So then it arrived. Oh, so then it arrived, and it was a blur. It was a massively exciting day when it arrived. The atmosphere in the hub, I think some of you were there on that first day. It was electric. It was so exciting, but it was also there was a massive sense of anxiety running through it. So we had to make sure that we were prepared for that. And one of the things we did to kind of help some of the shielding staff that were coming in to be vaccinated and also shielding patients was to set up a specific process for them so that when they arrived at the rec hall, they were fast-tracked straight through to a pod where they met with a vaccinator, they had the vaccine, and they sat away from the crowds so that they could try and be a bit more, I don't know, they were a lot calmer in that pod. It really helped not to be amongst other people. Some of these people hadn't been outside of their homes in nearly a year, so we needed to make sure that they felt comfortable. So we did that, and we got some really good feedback to that process. We also started making quite a lot of content for our staff, particularly in the beginning. On the first day, we filmed the vaccine arriving on site. We filmed it, the first reconstitution, which is, you know, pharmacy, turning it over and over and over and over. And we then filmed it making its way up the hill to the rec hall. Thank you. Making its way up to the rec hall and then going in the very first patient. So we filmed that entire process and then we edited it, and it was released by 2 o'clock that same day. So from the very first day, we had this transparent process for staff to be able to watch what was going to happen when they went for their vaccine. And we had a really good response to that because they felt like they knew what was coming and they felt a lot more confident about the whole thing. Thank you. The other thing we did was we created a lot of more specialist content for our BAME community. There was national trepidation by members of the BAME community, and we did have an initial low uptake by BAME colleagues, and there was lots and lots of reasons for that. And in response to that, Andrew Chilton sat down with a few BAME colleagues to talk about some of the individual problems that they were worried about. And then we also sat down with Carol, who is our manager for equality, diversity and inclusion, who was also very nervous and had a lot of trepidation about having the vaccine. And she was brilliant because she filmed her entire process. So we filmed her going in for her first vaccine, we filmed her in between the vaccines and how she felt, both emotionally and physically after having the vaccine. And then we filmed her second vaccine. And so that entire process was kind of documented. And we had really good feedback to that because people liked seeing that transparent and someone they knew going through the process. Thank you. Now, the subject that I know the most about is the hotline, because that was what I was asked to run. So we initially started with 22 dedicated call centre operators. We were also supported by volunteering. We got our temporary staff from bank partners, and then also the wonderful colleagues in PWIC set up their own rota within themselves to make sure that 2 of our seats within the call centre were filled every single day, and they managed that themselves, and they were just brilliant. I had a count up, and throughout the hotline's life, we actually had 68 members of staff come in and out, which was a huge amount of people, but we couldn't have done it without them. They really were, they were faced with so many things. There was a lot of, every day the guidelines changed about who we could offer to. The cohorts were very clear in kind of on the outset, but when you started picking them apart, you know, who got it and who didn't was very kind of blurry. So we had to constantly be having conversations about who we could offer it to, and also in response to that, we would change it hourly. So I would find out that someone could be offered it, so a certain healthcare provider, and I would run through, update the whiteboard, and then they would change their script in response. So these guys were really, really versatile. Thank you. The next slide kind of just shows one of the rooms we had, because obviously social distancing meant we just kept spreading through different rooms within clinical coding because we needed enough space for everyone to be socially distanced. But the emotional toll it took on these colleagues was immense. They were often saying yes and having these really emotional conversations of people being excited and seeing the light at the end of the tunnel, but also we were saying no to a lot of people because they didn't meet the government guidelines that we were having to abide by. So these guys saw it all in those first few weeks, but they were just such a brilliant team. They coined themselves the Bletchley Park Girls in the end because they just had this group pride in what they were doing. They were so proud of their purpose. Thank you. The next slide is just a bit of an insight into the IT system that we were using. The IT developers that developed this for us, our KGH IT developers team won an award for this system. It was so fab. They developed it they developed it literally in a couple of days, and then they stood it up when we first opened the hotline, and then the whole system evolved with us as we went through it. So the way we were reporting out of it in the first few weeks was very different to how we were reporting out of it by the end of the second wave of vaccines. And these guys were just brilliant. Every time I went to them with a different need, they were just straight on it and they made it work. And I had no idea how it worked, but they always made me feel like I knew what I was talking about. They were just brilliant, this team. Thank you. So by the end of the first segment of vaccines, we delivered 7,073 first vaccines, which was a real achievement. We were all very proud of that. And we were put into hibernation to prepare for the second round of vaccines, which was due to come kind of nearly 3 months later. Thank you. And in that next period, we did what I would say was our hardest piece of work, which was the rebookings work. So I'm sure you will remember when we first started our vaccines, we had a time frame of giving the second one in 3 weeks' time. That then changed to 8 weeks, and then it changed to 12 weeks. So by the end of the first run, we booked people into wildly different dates. So we needed to spend some time kind of bringing them all together into one block of bookings to make sure that we didn't waste any vaccines, and to make sure that everyone had their vaccine within the 12th week or close enough, which the government were being very strict about. And that took a huge amount of work. There was a little team of 4, and we manually moved 21,000 appointments to make sure they all sat within the same block. And trying to communicate that change with 7,000 people across the county was not easy. It's one thing to talk to our staff, which made up about 1/3 of our vaccines, but then there was 2/3 that were external. So trying to make sure they were aware that these rebookings had happened was really, really difficult. Thank you. And then all of a sudden we reopened. That was the quickest 3 months of my life, I think. And we reopened with an entirely different process. So what we'd learned in the first run, we applied to the second run. And it meant, and also in that time, the government had gotten even stricter about their guidelines. So we had a lot of daily reporting we were doing, and we had to make sure that the system within the rec hall reflected that. And it was much harder the second time round to make sure we didn't waste any vaccines, because the first time round we had the luxury of pretty much pulling anyone in that was walking past. If we had a spare vaccine, I would yoink them straight in and we would give them the vaccine. But in the second run, we couldn't do that because they needed to have had their first Pfizer, they needed to be in their 12th week, and it was just a lot more difficult. But we did manage it, and thank you. By the end of the run, we had delivered nearly 14,000 vaccines, which was a huge, huge achievement. And every time I see on the news the big number that's across the country, I think, KGH gave, they gave 14,000 of those, which is just amazing. Thank you. And when we closed down for the last time, we had this reflective session with just a few of the people that had been involved, to just think about, what we'd achieved. There were so many people that had been involved, and it was such a diverse group of people that had all worked together for this one cause, to make sure that we vaccinated as many people as possible. And one of the big things that is amazing to think about is that NGH and KGH were some of the very first COVID vaccine hubs in the world. Nowhere else was doing this yet. The UK was one of the first, so we were one of the first. But that also came with its challenges, because particularly during the rebookings, I remember standing there and thinking, I wish there was someone I could ask what I should do next. But no one's done this before, so there's no one to ask how to do this. We've just got to get it right first time. So to finish up, thank you. I thought I'd share with you some, I think they're very interesting facts. Each vaccine took 20 seconds minimum of prep time. So 20 seconds times nearly 14,000 vaccines is 77.2 hours, which, I mean, if you think that that's pharmacy in there inverting this vaccine over and over and over again, each vaccine, there was 6 in a bottle, and it had to be inverted about 20 times, and they did that for 77.2 hours. I mean, it's just amazing. Thank you. The other thing we were very proud of was that we applied and were granted a PSD, which is a patient-specific direction. And this was for our mums that had become pregnant between vaccines. So some of these mums were very early on in their pregnancy, and they were adamant that they wanted the vaccine. So we needed to get a special license to give them this vaccine. And we managed to get it, and then we brought them into a special clinic that we held on an afternoon, and they met with a doctor, our lead nurse, and a vaccinator, and they decided whether they wanted the vaccine, and then if they did, they had the vaccine, and they were so grateful. That was a really special afternoon, getting those mums vaccinated. Thank you. And then the final one, which is that our personal best as a vaccine team was that we delivered 390 vaccines within 8 hours, which was a delivery rate of 1 every 42 seconds. And we did that a few times, and that was a really special day when we did that. So I just wanted to say thank you to everyone that had been involved, because it was a huge achievement and it didn't come without a massive amount of work. So everyone did such a fab job. So yeah, so thank you.
Thank you very much, Alice. Yes, I see in the chat, Rabia is talking. I listened into the Yokoten session that this was discussed in the Global UNICEF Vaccinated meeting. So it was all very impressive stuff. Anybody want to comment on the story Alice has just told? It does occur to me that, you know, people forget that every time the government makes a small change in the rules, hundreds and thousands of people then have to find a way to make it work. And of course, it's very easy to forget what it was like going back to December, when nobody knew quite what was happening and everybody had high expectations. And we used to meet people out walking the dog who would express this huge joy that they had a vaccination. It never seemed to happen before with polio or chickenpox, but there you go. So Trevor, Mark, Andrew and Simon, in that order, please.
Thank you very much, Alice. And being one of those that was on the end of the needle twice, thank you for all you and your team's efforts. I suppose my question stroke comment is one that applies not just for the vaccine, but wider in the hospital. And that is, you know, the volunteers that we had working, and, you know, particularly in the rec hall, you know, they were there cleaning, you know, it was almost a sort of non-stop piece that they were doing. And I suppose it's how much both thanks, but ongoing thanks to those individuals that we can give, because they were crucial in what we were doing on those days. Okay, thanks, Trevor. Mark.
Thank you, Alice. Thank you, Alan. Thank you, Alice and Paula for sharing the story today. You know, it is a phenomenal achievement, and I suppose I just need to say right at the outset how proud I am of everyone in the team that came together to deliver this a fantastic achievement. And it really strikes and it hits the chord, Alice, when you say, and when we go back and look 6 months, we were some of the first in the world that were doing this. You know, this was not something that here's an SOP, follow this, because we've done this 100 times before. It was. And, you know, as I was over in the centre, it was amazing to see how calm. So it's interesting when we say every 42 seconds, you never experience that as an individual in that vaccination centre. You never experience it in that hub. And I think that's true testament to everybody pre, during and post attendance. And you're totally right, Trevor, in terms of the volunteers. And this follows on nicely, doesn't it, from our story we had from Claire last public board meeting as one of our volunteers, and the numerous roles that Claire had undertaken in the We Care Cafe, and then of course in the vaccination centre. And we will look to continue to celebrate and thank them for their work. I suppose I just wanted to share on that point too, that we have started some very good work, again, that Paula is leading in relation to our voluntary services between Northampton and Kettering. So how can we grow and expand these even further in line with the people plan that we approved in March? But my overall message and my overall statement is not one of question, but it's one of thank you, Alice, for presenting today along with Paula, and indeed to the whole team for the huge contribution and supporting this particular programme. Thank you.
Thank you. Andrew.
Thank you, Alan. So thank you, Alice. Thank you, Paula. Really quite amazing work. Really, the vaccine was our moon landing, wasn't it? And you really were kind of Houston Space Central in terms of making it all happen and be there. You know, in my lifetime as a doctor, we've had 3 really big new diseases appear on scene. We've had AIDS, the discovery of hepatitis C, all viruses, and now COVID. And you know, it's been a fascinating time, and just seen the science roll out as this happened, getting to learn and understand about the vaccine. It's been truly an amazing process and very exciting. And the logistics behind it were truly incredible. It's nice not having to ask someone what to do and just make it up. And so well done.
Yeah, thank you, Andrew. It's there's not much point in inventing a vaccine if you can't find a way to stick it in people's arms. So the second part of the test was quite remarkably well met. Lisa.
Thank you. Just to echo the congratulations. And then, do we think if there is a booster dose for the general public that we will have to administer the booster in the autumn.
We'll come back to that. Simon.
Thanks, Alan. So I first heard this presentation at the Kettering sessions Rabia hosts, and I hope you can see why I thought it was worth bringing to the attention of the board today as something that we should all share and celebrate in. I guess I don't want to repeat what others have said. I wanted to, I guess, pick up on something that you said, Alice, because I think it speaks to the heart of what was great about this, but also I think something we need to find a way of bottling and taking in. You said 4 people, I think, changed 7,000 appointments. And when you think about that, if we had more of that as we face some of the challenges that we've got in the years ahead, what miracles we could further achieve, I think. And those 4 people didn't know how to do it, as you said. They did it because they knew something needed to be done, and off they went and they did it and they made it happen. A truly incredible achievement. And I just wanted to say again, thanks. And just for us all to reflect on that, 4 people and 7,000 appointments.
Just to jump in there, Simon, those 4 people, 2 of them left retirement to help us with this programme, and they were both from the volunteer services, and we had to move them over to bank because they were doing too many hours. So yeah, they were truly incredible. And one of them was 8.5 months pregnant, and she left us for maternity leave just as we started our second run. They were a really amazing team.
Okay, thank you very much for that. Just coming back to Lisa's comments. Does anybody have any information on the booster dose program? I don't think there's much out yet, apart from the fact it's probably a different vaccine. No, Mark's saying no, we don't have it.
Alan, it's all speculation at the moment. Yeah. We're not.
That's what I thought. That's what I thought. So we'll no doubt be ready for it when it happens. And certainly at the Yucatan session, Rabia, we had quite a lot from Chris Palo as well on the system opportunities. And you know, it's worth saying at the moment that nationally we're running at about 680,000 vaccines a day, and that is 10 million in a fortnight. You know, so if you think about the pace at which it's moving down towards the 18-year-olds, Northern Ireland is already there. The rest of the UK is only a percentage point or so behind, which is, you know, as the papers talk about, the race between vaccination and Indian variant seems to be a fast race in both places. Okay, look, everybody's said what they've said. Thank you very much, Alice, for coming along and talking about it. It is a terrific story. Well done. Nice to see a career developing nicely as well. So thank you very much for your time and your efforts this morning. Everybody's very pleased to hear the story. Thank you. Okay, moving on. Lisa, your hand's still up. I'm assuming that's a legacy hand. You're all very welcome to the main board meeting. We have apologies from Lynn and Damien. We're welcoming Rabia as Deputy MD today, but interim MD from the 1st of June. So thank you very much, Rabia. It's very nice to see you. We all know you well. Minutes of the previous meeting on 31st of March. Are you happy to refer record? Yes, good. Thank you very much. The action log only has 1 item in it, and I think it's complete, which was something for me to do. So it's always pleasing I managed to remember to do it. Thank you very much. Nothing else anybody's concerned about in the action log? No. Chairman's report. I just want to talk about a couple of things we're picking up today. The planning submission to the ICS. We've talked about this a number of times, and today's the day when the board will look and say, have we got the balance right between people, our people, patients, the recovery rate, and money, and that's how it is going to be discussed and presented. It is worth remembering that this is only for the first half of the year, what will be called H1, and it is difficult when here we sit in May and we have no idea what the ask is for half 2 either. So apart from the normal uncertainties of another wave of COVID, another variant, winter and flu season, we actually are in a position where we don't know much about the money, and we don't know much about the ask for the second half of the year. So just remember the kind of context in which we're holding that debate. So that's the first thing, and this is the time the board says, okay, we're happy that you've got the balance right on that. And the second bit that's important on the board today is the ICS work. The work is going on at a pace. It's important we get this right. It's important we get the arguments around 2 places aligned with our local government partners. It's important that we get the system, the planning of the system in place. This can sometimes feel a bit esoteric, but in this case, it's going to be some big decisions made quite quickly. And I think our position will be discussed about that, but we need to think very carefully about how we balance what might be called lift and shift, just leaving everything pretty much where it is and moving it into the new organizations, or whether it's a time to be a bit more radical. So again, some tricky and interesting decisions. And the final thing to reference is the nursing and midwifery strategy. The board's seen it all before in development session, but just to remind you, in case you didn't know, there are over 3,000 nurses across the group, and if you add in the HPs, it gets nearer 4,000. It's a big chunk of our workforce. So although we have a lot of strategies, they're all compatible, which I hope they are. They're all compatible, and they're all important in how people think about what their contribution is to both the group and the opportunities that come with the group. So I think we've got a lot of interesting things to talk about in the board today. Simon, yours.
Thanks, Alan. So start by just picking up on that point around the planning submission, if I might. Today, I really want us to have a good discussion about the 3 aims that I talk about in my report. First and foremost, have we been ambitious in our delivery for patients? I think just this morning, we will have all seen news stories talking about the unprecedented backlog the NHS faces, the need for surgical hubs to clear routine operations. And it reminds us, doesn't it, really, that whatever type of operation people need, it is a person in need. And I think it's right that we ask ourselves the question here, have we been sufficiently ambitious in what we plan? Secondly, of course, we need to be mindful that in delivering that aspiration, we have to take with us our workforce. And the second question I think we need to ask is, have we been sufficiently ambitious in terms of how we care for the people who will care for all of us? Because if we can't deliver that well, then a lot of other things that we want will really not happen in the way that we want or when we want. And then the third question is, we are now gradually starting to return to some form of normal business, by which I mean, in this case, financial normal business. And therefore, the question has to come, have we done all that we can to live within our means prudently? And at one level, those could be seen as really quite competing asks, but we've got the job of trying to reconcile them. And in our board discussion today, I want people to feel free to kind of explore those parameters. We'll have, I think, a good chance to reflect on those issues. And as Alan said, the thing that we'll be signing off today is, do we think we deliver in half one? Half two is a whole other ball game, and we'll spend some time reflecting, I think, in the months to come about how we're going to get into that place. I think one of the biggest challenges that was highlighted for us as a system in our recent quarterly system review meeting was getting a system strategy on the money. We were also commended, though, for 2 things, in particular our elective recovery work. And again, it's another real success story that doesn't often get talked about. But one of the things that they asked of us in our quarterly system meeting was, could we help other regions, other parts of the region, because we have managed to keep our elective work going as well as we have. We were also particularly commended for our support offer to staff, and marked out as one of the best in the entire Midlands region on that. So lots to talk about in that space. Second thing I just want to pick up is just really, again, echoing what Alan said. We have, I think, 1,400 nurses in KGH and a load more other people in AHP professions. And today we're going to talk about that, but I wanted to reflect for a moment on the International Nurses Day. And really, I had a chance, I've shared my story there, but to remind us all, I suppose, of the fact that ward leadership matters. It really, really matters. And one of the things that I hope we can all do as we go, as we start being able to come back into the hospital, visit, go out and see people, is really spend some time supporting those ward leaders who are the sharp end of care on a daily basis. And it's also an opportunity for us as a board, and me on your behalf, to say thank you to each and every one of those 1,400 nurses, all the AHPs, all the midwives who are in our organisation every day doing fantastic, innovative things for our patients. And when you have a chance to reflect and we have a chance to talk about the nursing strategy, my question for us here is, do we really want, do we think that those aspirations expressed in that strategy really deliver for that group of staff who we are trying to bring to the fore? Because it's critical that we do, they're the backbone of the organisation. Finally today, a little bit on the ICS. The work on that is accelerating. Just like to thank all the non-execs who've been involved. It's highly complicated stuff because commissioning systems don't change that often, once every 10 years, I think, on average. Again, we need to reflect on that to make sure that we are designing a system that really meets the needs of patients. If we get the design of those commissioning systems wrong, ultimately it makes the job of caring for patients harder. I think one of the consequences of the current system and the long, slow retreat that we have been on over the last number of years away from it has been trying to put the patient back at the heart of the commissioning and contracting system. And this is that opportunity for us. So as we reflect on that today, I hope we hold that thought in mind. Thank you.
Thank you. Just pause there. Any comments or questions on anything we've said up to now? Nope. Debbie.
Thank you, Chair, and good morning, everybody. So I'm going to start by saying that since I wrote my report, the number of our COVID positive inpatients had actually increased to 5, but that's now decreased again. So today we've got 2 COVID positive inpatients in our hospital. I'd also noted in my report that we've started to welcome back visitors, and we've also welcomed back some staff who have been shielding. So the hospital's starting to feel busier. A&E activity has increased, which I'm sure will be noted later on in the agenda by Faye. Last week, I'm really pleased to say that we launched our staff listening events. This is an open meeting for any member of staff to attend and talk to the exec team and other colleagues about things that frustrate them, their ideas to improve care, and offer suggestions for changes for their working lives, but also to make care better for our patients. So the first 2 events have been attended mainly by ward staff, but I was really interested to hear about some of the things, especially within the digital arena, where we need to put in place some additional equipment, for example. So some really quick wins to help our staff and help them speed up processes on the wards. Now, I think with this, it's really important that we don't just listen, but we actually action and we feedback. So we will be doing that through formal mechanisms such as the monthly staff briefing, but also more informal means such as when we are walking around the organisation and when we're talking to different staff groups, making sure that we are sharing the stories of the changes that we've made throughout the hospital. So I think everybody is aware that over the last couple of months, we've celebrated most days. We've had Nurses Day, we've had Midwives Day, ODP Day, HR Day, which I'd never heard of before. That's just to name a few. But in my report, I've highlighted some of our individual staff and teams who've won awards over the last couple of months, and that's really it's really pleasing to see, actually, because it has been a really busy 12 months. So 2 of those, again, in the digital arena, our Chief AHP Information Officer and our Chief Nursing Information Officer, both have won awards for being digital champions, and one of those quite a prestigious award for the Chief Nursing Information Officer. So really well done to those people. I was also really pleased to hear about the Lotus Team. So this is a team of midwives who provide continuous care or continuity of care to our nurses, to our mums who identify as BAME. And they started in April. They're doing a great job. I'm hoping to go out and meet with some of them over the next couple of months. So just wanted to highlight that. And finally, as we move further out of lockdown, we have started to restore some of our services, and we're going to hear about that, as Simon said, later on in the agenda. So I think today it's looking fairly positive outside, and we're starting to see a change in the weather. However, I don't want to be the voice of doom, but winter is only a few months away. So it's really important now that we start to plan for that. It could be a challenging winter. It's likely to be, with increased numbers of patients attending with flu and RSV in children. So we will bring our winter plan, which is integrating into the system plan, to the committees of the board over the next few months. You've already noted Rabia, but obviously I would also like to congratulate Rabia, who will be, as you say, starting on the 1st of June, but also like to take the opportunity to thank Andrew. Andrew's been a great support to me over the last 2 months at Kettering and has clearly done a huge amount for our staff and patients over the years. So I'll stop there and take any questions. Thank you.
Okay, thank you very much, Debbie. I like people who win awards, and I occasionally chivvy people. I note this morning the HSJ Awards has extended their closing date, and hopefully we'll have a number of candidates running for that, because I think there are an awful lot of good stories in both hospitals that we can take forward into that. And it's you can only win awards if you enter for them, so it is quite important that staff get some forum in which to show off what they've done and get their appropriate reward. Right, any other questions on any of that? No. Okay, where am I? Integrated governance report. So we're running through this in order in the usual way. Debbie, are you orchestrating this?
No, we are going straight in, if that's okay.
Leanne on quality and then Chris, and I'll take them through in the normal way. Okay, thank you very much, Leanne.
Thank you. Good morning, everybody, and thank you very much for giving me the opportunity to talk about the integrated governance report regarding quality. So I think firstly, it's fair to say that obviously in terms of quality, that's often impacted on by our staffing levels, and I'm pleased to report that with our returning staff from shielding, our international recruitment, our staffing position is looking much stronger. So it's really good to see that actually we're starting to have a downturn in our agency spend, etc. So that's a really good thing to see. So the main aspects for us in terms of quality currently regarding our falls, we had 3 falls, and we've previously reported our falls action plan here. And we are continuing to work through the summit action plans with our practice development team, looking at the sensitivities around our documentation and our audits for that. And I think the other bit I wanted to add in terms of complaints at the moment, we still have not returned to our previous levels of response times. And what we're doing is considering at this stage increasing the number of staff that will be available to that team and to the divisions to make sure that complaints are responded to in time. but that we actually take the learning from those and can evidence that that learning has happened in practice. So there's quite a lot going on in that area. And I'm sure Faye will come on to this when we talk about performance, but I'd really like to take the opportunity to thank the wards that have been moving around the organisation over the last few months. And we saw another change last week with our D&C staff, who actually were our popular staff, moving now into Sir Thomas More ward. And we've worked quite a lot with that team to make sure that they have everything they need to continue to be in their good route of performance. So I think from an integrated governance report, from a quality perspective, that's me today. Thank you. And I'll hand over.
Thank you, Leanne. So page 41 of your pack shows the discussions that we had in the committee. I just draw two things to your attention. First of all, as Leanne has already mentioned, the performance position and the attendance in the emergency department. The other issue that I would just draw to your attention is that we had a never event in the ophthalmology service, and we discussed this. And it's a never event that I'm aware has occurred, a similar never event has occurred in other organisations. So this is perhaps a pattern that needs to be investigated nationally, or well, regionally and nationally, rather than just as a single organisation. And I don't think I have anything else to say other than the performance position is outstanding compared with other organisations. Thank you.
Okay, thank you for that. I know the A&E attendance, ED attendance numbers are mirrored in Northampton with record numbers attending, but the same kind of pattern of admissions and handling of patients in other ways. So we're clearly seeing a normal, or what is becoming a normal pattern, and somebody's going to have to do something quite carefully to think about how we change that pattern. Right, operations, Faye.
Thank you, Chair. So I'll start off with urgent care. So as we've already mentioned, yes, we are seeing an increase in our attendances, and we are close to our pre-COVID levels. So definitely really heating up. We've seen a particular growth in our minors attendances, and local intelligence is telling us that it's mainly down to the fact that patients are struggling to access their GP appointments. But we are doing some focus work across the system, looking to see what we can do to improve that position. That said, we have a really good streaming process at the front door in ED, with a number of these patients being streamed directly into our new Miami unit, which is our minor injury and illness unit, and also at SDEC. So that is helping us manage the flow and prevent overcrowding. A good news story in terms of Aed Performance is around our ambulance handovers. So we have some of the best performance in this target across the country. And I'm really pleased to report that in April, we had no 60-minute ambulance breaches, or otherwise known as black breaches, in April. And indeed, we haven't had one of those since the 18th of March. So considering the demand that has been put on our department, I think that is really very, very impressive, and obviously is the right thing for our patients. So in terms of other standards, just bring your attention to our Rtt performance. We continue month on month to improve our position against that target, although our main focus is around reducing our 52-week breaches. As you know, we have been under pressure for the last few months in terms of those. In April, we had 7 patients that waited above 52 weeks. And in May, we are reporting 0. That's a tremendous amount of work that the team have had to do to make that happen across the whole of the organisation. But we're really pleased with the direction of travel that we are going in. We now have set ourselves a stretch target. So we're now striving towards meeting 46 weeks in July and then 30 weeks in December. So some services are already meeting that target, but some services aren't. But we'll continue to really monitor that really closely. I'd just like to make a point of note that our referrals are increasing. In March, we saw an increase of 22%, and in April, 6%. So it's something to watch in terms of our waiting lists. Diagnostics, another good news story. Although we slightly missed the target, 1.4%, which was disappointing, we actually are doing really well in terms of this target nationally. And I'd just like to mention a special mention to radiology, who actually have had a number of curveballs dealt to them and actually achieved the target for all of their diagnostics that they provide in the department. So that's really very impressive. In terms of cancer, 62 days continues to be a pressure point for us, but I'm pleased to report that performance is improving month on month. And most importantly, our numbers of patients that are waiting over 62 days are coming down month on month. We have a trajectory for KGH, and we are hoping that we will achieve this in July. And as things stand today, we are on track to deliver that. The final point I'd like to raise is around our super stranded. And you may remember back in March, we peaked at having over 94 patients who were waiting for over 21 days in our beds. In April, that dropped to 80, and today we're sitting at 67 patients. There's been a phenomenal amount of work around discharge and focus to ensure these numbers are reducing, but most importantly, to get patients to the destination that they need to get to. The positive impact of this has been that we've been able to return a 20-bedded ward back to surgery. And on the 24th of May, our first elective orthopaedic patients started to come through the doors at KGH again. So this is a real achievement and would not have been able to happen without the dedicated support that the teams have given to reducing length of stay and those super stranded numbers. And as Leanna's already mentioned, there needs to be a big thank you to Dean C, Thomas Moore, and others, because in terms of moving all the beds around to make that happen. So I'll stop there and take any questions. Thank you.
Okay, thank you. Anybody picking up on anything there? No. Lisa, do you want to add anything to that, since Damien's not here?
Yeah, look, really just to echo a lot of what Faye's already said, big congratulations, particularly on some of the A&E performance, given the increased attendances, calling out again the no black breaches, which was great to hear. And then again, also the focus on the super stranded, very positive. The one thing I'd just like to note is the RTT, look at the IGR, the overall average RTT numbers seem to be getting flatter, masking the improvement that Faye was talking about. But really, this is more statistical thing where what we're doing is reducing the long tail, reducing the number of people in that 52-week category. Over time, that will start to shift the average. But just to note, when you don't see it moving, that's why Faye's comment about the focusing on the people who have missed that target by the most is the right place to be focusing.
Thank you. Lisa, and then Simon, and then we'll move on.
Yeah, just a query really, and perhaps it's Robbie or Andrew can answer whether we're seeing in the increase in referrals and the presentations of cancer, more people who are later in the journey than we would have anticipated. So staging of cancer being later, so more severe illness, because I think that's something that we need to think about in planning as well.
We don't have any specific data on that, and there is there's no real sense at the moment in the various tumour site groups that I'm involved in that this is the case at all. I think it's something when we get amalgamated data and the cancer intelligence networks do their analysis of that, that's when we'll get to know that. But I think just on an individual anecdotal trust level basis, I'm not seeing that, but that's not very scientific in terms of an answer. And I think, our numbers are just far too small to draw any specific conclusions.
Okay, thank you for that. Simon, last one, then we'll move on.
Just want to call out two things. One, great work on the super stranded, but it highlights the relationship of what we need partners to do for us, because we wouldn't have delivered those numbers if partners hadn't have done what they've done. And the incredible importance then, as we talk about the ICS, of designing continued success around those and other measures into that way of thinking about the world. The other is just to call out the new A&E standards. There are 10 of them, and I would commend to the Quality Committee a dialogue through June and July. So by the time we come back at the end of July board, we're in a position to start understanding, as we apply those metrics across our performance, what are we thinking? What does it tell us? What new insights does it give us? What new challenges does it present? Because in the context of the winter plan, that'll be where our debate will be at by then. But thanks to everybody who has made such a good scorecard possible. It's really good to see.
Thank you for that. And it does point a little bit to the planning and organisation of the ICS and the provider collaboration going forward, in that one of the issues that does arise is the opportunity to align incentives for out-of-hospital organisations to see the reason for speeding up the discharge of our patients, because it allows the surgical and elective side to work more efficiently and productively. So there's always an issue in the design of all of this and lining of incentives. Money then, Anil.
Good morning, thank you, Chair. In terms of finance, there's probably 4 key points, but the first thing I wouldn't say is on the slide deck, you'll see there's a slightly shortened list of slides in there. And that's again because we're updating those in light of the financial arrangements for H1. So for an example, there's not an ERF slide for Elective Recovery Fund, but we'll be adding that for month 2. In terms of the I&E position, our in-month position is a £1.1 million deficit. That's in line with the plan we had for April, so there is no variance. It doesn't include the ERF income because we've got an indicative value of 775,000, but that needs to be still validated with NHSEI. Again, you mentioned earlier that the plan is very much focused on H1, so it is April to September. And at the minute, the plan is to break even on that, but we'll be talking about the plan later, so I'll go into the detail on that later on. Income is under recovered slightly by 400k, but we recognise that. We knew that was going to be coming through in month 2, and that's been offset by pay, non-pay, and some additional COVID income. In terms of agency, we have a ceiling this year of 10.8 million. In month, we spent 900k, which is broadly in line with the plan, so that's okay, we've broadly broken even, so we're living within that ceiling at this point. We have an annual target this year of £7.5 million efficiency. We've delivered savings of 136k in April, primarily down to procurement and workforce plans. There was a shortfall due to some plans that still need to be identified, and we're working on those and developing those to make sure we deliver those for the first 6 months. In terms of capital, we've got a capital allocation, which is part of a system envelope now. So it's very much a system envelope that then gets agreed by the health partners as to the allocations for each trust and organisation. Our agreed allocation is 13.4 million. Against that, we've agreed a plan of 14 million, recognising we have slippage in year, but we'll make sure we fully utilise the funds available, i.e. the 13.4. It does include the development of the HIP2 programme continuing and the Energy Centre. They're the key highlights I really wanted to mention. If there are any questions, I'll happily answer those. Thank you.
Thank you for that. Lisa, do you want to add anything?
No, not really. The key things for us are how do we now, and it links in really to Simon's initial comment about how do we get the right balance between the ambition and the financial efficiencies, which really comes to bear in the numbers we looked at in the committee as part of the SIPS development and delivery.
Okay, thank you. Mark, people.
Thank you, Chair. So I will take a majority of the report as read in terms of the metrics and statistics. We have those, and we talked about them at our first formal joint people committee in common on Monday, which I'm sure Janet will come on to talk about. I just wanted to call out a couple of items from the paper. The first one is in relation to sickness absence, and so we know we've almost plateaued in our performance at the moment. So we're re-evaluating our sickness absence interventions and our health and wellbeing interventions to make sure that we can support colleagues back to work at the earliest possible opportunity, or indeed, dare I say, in the best possible scenario, and prevent them from being unwell in the first place. So we're just going in to have a look at that and to see what we can do. We've heard already today in terms of some of the support we have been able to undertake by bringing our shielding colleagues back. We just need to see what we can do for those that are suffering with stress or anxiety or musculoskeletal issues, as they are the two now biggest reasons. We also, for absence, we also have some colleagues who are suffering the effects of long COVID. So we're looking into support for those colleagues too. As part of that health and wellbeing offering, as many things are discussed as a system, and as Simon articulated earlier, in our quality review meeting from our regulators last week, we were called out as an advanced area in terms of our health and wellbeing across the system. And as we're in a public meeting, I just want to bring to everybody's attention that we are once more running a virtual health and wellbeing festival this year at the end of June. I bring that to your attention because obviously it would have happened before we meet again at the end of July. And we will send details around for colleagues to that. Again, we have a number of celebrity speakers, but importantly, our own staff and our own professionals talking to ourselves in relation to support that they can offer across our services in the system. The only final 2 points that I would leave upon on this particular item is that I'm really pleased to announce that this week, the 25th, this week, we have commissioned our first joint leadership development programs across KGH and NGH, and that's with our colleagues developing and learning with one another in a leadership environment. So that's really positive because we know if we collaborate and we develop together, then that will further help with services in the future and bear out benefits to our patients. And the last point for me in here on this particular item is in relation to our people partnering pledge as part of our people plan. I think it's fair to say, and I shared it at the Northampton board yesterday, that we have been found wanting in some of our employee relations activity recently in terms of our case management. And we're learning and looking into what we can do better around that, taking into account obviously the Dame Harding recommendations from 2019. And on that basis, within the People Committee and our next workshop at the end of June, we'll be bringing a paper in terms of the actions and changes we are making in relation to our disciplinary process and incorporating a just, fair and restorative culture. And I hope to bring an update to the board at the end of July in regards to that situation too. Thank you very much.
Janet, anything you want to add?
Yeah, just quickly, I think that gives a really great indication of the learning that's going on between the two organisations, particularly through the approach that's being taken with the Joint People Committee. I want you to be aware that we've received assurance in terms of the progress and actions towards the delivery of the Group People Plan, but there's a recognition of the challenge, and there is something in terms of the discussion we had about managing expectations. We also noted the requirement for cultural change, and I think the fact that there's a lot of shared learning, shared experience is really also a delight, if you like, because actually there's some really inspirational people across the piece that are involved in all of that. And actually the People's Committee, I think, has got some really interesting people, great leadership in terms of the contributions that are being made. One of the other important things is about the review of the group workforce planning that's needed, and the fact that there's progress being made with regards to that. And the committee was able to bring forward some challenges. So I'm really grateful for the input from my colleague Neds, but also everybody who was involved in the committee. Thank you.
Okay, thank you, Janet. Anybody got any questions on those two topics? It's pretty clear cut. Yeah. Okay. Where am I now? Strategic Development Committee. Not a lot to say there. There's a little bit of a pause, but Polly.
Thank you, Chair. Yeah, as you say, we are still waiting. We submitted the strategic outline case a few months ago to the system. We have received, are now working through the feedback with them, but we have yet to receive any formal feedback or permission to move to outline business case, although we have already started some of the detailed planning and working with our clinical teams around that, but no formal update or feedback.
And if you do like long documents, the Sustainable Travel Plan and Car Park Management Plan is an excellent read at 2 o'clock in the morning. But it has got full of interesting stuff in it too. Okay, Group Digital Committee, Andy.
Thanks, Alan. Yeah, so you'll see from the update that we're now sort of into the swing of things as a group committee. This month, for the first time, the updates were provided using the new group digital strategy themes. Those updates will continue to evolve. We're starting to do some benchmarking on the 104 targets within the strategy, and we'll report those as we go on to the committee. I'll let Alice pick up on a couple of the elements that we've got in there about the announcements. The only other thing that I would mention, it's not in here, but it is worth noting, just very quietly, the scanning has started at KGH as part of the EDMS programme. There's over 2,000 patient records that have now been scanned, and it's very much the start of, as we see those piles of paper start to disappear. So it's quite a gradual process. It's been done in a very specific areas to start off with, but it will just gradually take effect over the whole hospital. And I'm really excited that that's actually started, because it's a big moment for us. Alice, I'll hand over to you.
Thanks, Anne. Thank you. Yeah, just to confirm, as Andy said, we now have digital directors in post at both hospitals, which is great, and a good initial step in Andy getting his team together to deliver the ambitious digital strategy that we've got. And it was really good to see their reporting at the group committee now start to align with that strategy, and us align our KPIs and everything and our targets along to that, because the only sure way we're going to make sure we're really focused on delivering that strategy, and to some extent only that strategy, and not getting too diverted by other things as far as possible. So really good to see that developing. Also really good to see those two digital directors in place, and I think they both bring different things to the team, which is great to see. The other thing I just wanted to highlight quickly is that we also spent quite a long time discussing digital risks, which I think is relevant, because I know it's something that we've talked about a lot around how the group committees do that. We're starting to go down that road of harmonising how we look at them across both sites, and asking sensible questions around why do we have this risk at Kettering if we don't at Northampton, and so on, and getting some interesting discussions coming out of those. So the team has spent a long time looking at that, and thanks for their work on that. And we're starting to have a much clearer view about the different risk pictures at the two organisations.
Thank you very much. I was at the clinical leaders meeting this morning in Kettering, and the chief clinical information officers were very positive about the achievements and the plans for in the digital agenda. And I was keen to make the point that whilst that's an important enabler, we don't expect our clinicians to wait for everything in the digital world to be perfect before they decide to step forward. But I think that was, broadly speaking, a reasonably accepted view of the world at that point. CPC, Simon.
Thanks. Just a couple of items really to draw to the committee's, to the board's attention. The first is to commend the work that the Directors of Governance led on behalf of both executive teams on really starting to formalise our approach to group risks. That is an ongoing piece of work, and I'm looking forward to the upcoming discussions where we really start to understand in more detail how we play through into our operational discussions the things we are most concerned about. I think there's also been a really positive discussion around risk appetite, and the challenge there is how, when you've identified your risk appetite, do you bring it to life in the decisions that you actually take operationally, which I think is a topic we're going to need to come back to, not just in CPC. I would also commend that ongoing thinking and discussion to all committees. Upcoming, I'm looking forward to the 14th when we start really bringing to CPC work on the clinical strategy. Clearly, one of the most important debates that CPC will be hosting is how we intend to dispose services across the two sites, what the opportunities are, what the challenges are. And I think just to signal, I think that's a really important discussion for us to have. And I think I'm handing over to Alice.
You are indeed, although it might be worth saying that just reminding other non-execs that they are welcome to attend the CPC, as we discussed at the exec away. And indeed, Alice is nodding. So I think Alice and her opposite number at the other end, Rachel, would welcome other non-execs in sharing the burden of discussing strategy and culture there. Alice.
Yeah, absolutely, Alan. And I think not to say that we won't have conversations twice in the separate boards, but as many as people can be there at the original conversations, that's really helpful and stops any miscommunications and feelings that people haven't been involved in those discussions. So please do, if you can, come along to some of those. The only thing I was going to add, I think, to what Simon said, which is a good summary of where we are, I think, is that as we acknowledge, certainly at the non-exec away day, and I suspect some conversations were had perhaps by the exec team. I think the main challenge for us at CPC is also thinking about how we really spearhead those 3 clinical areas that we've asked to collaborate initially. And I think we've reached a bit of a slower point with those at the moment, and we need to think really carefully about how we make those real trailblazers for what we want to do in a number of other areas and how we support them to do that. So I think that's the sort of the thing that's going around in my head that we need to think about after discussions over the last couple of weeks.
Okay, anything at all as we come to the end of integrated governance report anybody wants to pick up on in all of that? No. Okay, I do think it's worthwhile pointing out that the Kettering integrated governance report was held up as a national exemplar by NHSI in a webinar run by Sam Riley, who some of you will have met when she presented at us about the use of CPCs, SPCs, statistical process control graphs, all of which are in the report today. And I would also say that I think the explanations below the SPCs have improved considerably in the last period. So I think people are to be commended for that. As a group now, we need to align the IGR reports in that they look the same. We're perfectly capable of reading whether they're KGH or NGH across the top. So I think we need to start to say to Northampton that this is a national exemplar and these are the kind of models we wish to take forward. Now, there's always a little bit of cross-learning to be done, but fundamentally, let's all get ourselves on the national exemplar stage for this. Trevor.
Thank you, Alan. Just briefly, on the audit committee that's part of the IGR, the one thing, there's a number of notes there for the board, but the one that I have to bring the board's attention to is that under the delegated responsibility, we took a paper on going concern, which we approved. This is part and parcel of how the audited accounts are compiled. What's important there is that we've moved in 3 ways in the last 12 months. One is the national restructuring of the debt of NHS trusts, which has massively improved KGH's position. The second is the financial position at year end this last year. And I know Andrew was very pleased to give the view that we were actually in surplus, which wasn't something he'd heard for a long time. The third one there is that the current arrangements for NHS finance means that the position for the trust is more stable than it has been for a long time as well. So going concern, we approved, and the rest of those are for information there, and one is on the agenda.
Thank you for that, Trevor. I do apologise. It's you are in the report, but you weren't on my list in the right place. So I do apologise for that. Right, audit committee. Okay, where am I now? Planning, 2021-22 planning. I think Polly is leading on this with contributions from Anil, Mark and Faye on the obvious relevant topics. Already talked about it at the beginning as an exercise in balancing up how we look after our staff, who then look after our patients, and what that means for the money, and have we pushed ourselves as hard as we can? And does this reflect the best we can do for our patients and the best we can do on the staff welfare front? Polly, over to you.
Thank you very much, Chair. I think we're just going to put one slide up, which is the next slide. So just in terms of context, so every year NHS organisations are required to submit an annual plan, and the papers that have been sent around in the pack summarise ours, as you say, Alan, in the context of how we are going to be supporting our people over the next year and their health and well-being after the year that they've been through. How we're going to be recovering our elective waiting times for our patients. We know nationally some of the elective planned waiting lists are longer than they've been for many, many years. So how we're going to recover that for our patients locally and make sure they get access to the treatment that they need in the timely way, and how we're going to deliver financial balance. And there's possibly some challenges between those three. So I think I'd ask 3 questions really to consider as we go through this for board members. So first being, as you say, how we make sure, are we ambitious enough in these plans? Are we doing all that we can possibly do in those 3 domains? And are they realistic? Are we got the right balance between the 3? And how are we going to manage any tensions throughout the year that might come up between those 3 balances? So in terms of, there's a couple of technical differences with this submission, and there have been in previous years. First one being that this is a plan just for the first half of the year. So there will be guidance that comes out and we will need to do a plan for the second half, but this plan at the moment just takes us through until September. And the second technical difference is we aren't submitting this directly. What we're doing is each organisation across the system, across the county, is looking at their own plans. These are then getting brought together and the system as a whole is submitting one joint plan. And that is a significant difference. It's obviously part of the drives and the movements towards ICS, and rightly so. So there are some strong incentives in the guidance and in the plans to work together with our partners. And one of the key ones on that is ERF, which is Elective Recovery Fund. So the Elective Recovery Fund is a financial incentive that systems will get if the system delivers a set amount of elective activity. So if it increases up to 85% of the activity levels that the system was delivering pre-COVID, then we get some opportunities to access this Elective Recovery Fund. And that's really important for us because it does help our system financial plans and being in balance, which Anil will come on to in a moment. So I'm just, part of one of my roles is to chair the System Elective Care Board. So I'm going to give a quick update on where as a system we are with the elective plans, and then I'm going to hand over to Faye. And Faye's going to give a bit more detail around the Kettering perspective and the Kettering position on that, and how confident and realistic she feels the Kettering plans are that we're submitting. She's going to then hand over to Mark, the Chief People Officer, who's going to be taking us through what that means for our staff and how we're going to be supporting our staff in that journey over the next 6 months. And then Anil will finish off to bring together what that means for our financial plan and our submission that we're making in that domain. But before I hand over, just in terms of the system elective care plan then, so the final activity forecast submission that we will be giving in next week, we do believe across the system is robust and it is realistic. It's been brought together from a bottom-up position that I'm sure Faye can explain across all the providers. Does include quite a significant amount of independent sector activity, but that is in line with what our system would normally be delivering. Our system does have a high level of NHS activity that is delivered through the independent sector. And so we're continuing to work with the independent sector this year to make sure that we continue to do that. And that makes a really positive difference for our patients in the county and how quickly they can access care. So the final submission is an improvement on the draft submission that we put in back at the beginning of May. And the improvement really is because both of the NHS trusts, Kettering and Northampton, have been able to open up more capacity safely. So that's outpatient capacity and theatre capacity. So obviously we need to protect green pathways and our COVID and screened and swabbed patients. And we've been able to open up additional capacity. So that has shown an improvement in our final plans that we're submitting. And at a headline level, when you compare our system activity levels to pre-COVID, we do improve month on month as we move from April to September. And we start to get towards pre-COVID activity levels when we get towards August and September. We're not quite there, but we are sufficiently high enough that we do meet the Elective Recovery Fund, the ERF, baseline, which is 85%. So we do achieve that. So we are predicting that we will be able to get access to that funding into the county. There are some risks in that though. The two key risks really are our staff and our theatre staff and our ADPs in particular. Those are the staff that over the last year moved into intensive care units across the county to support our COVID response. So they've had some quite difficult year, as have many of our staff, and we're now asking them to work, just as hard to recover our elective waiting time performance. So we really need to make sure that we're giving them enough support and they are resilient in that. The other key risk is making sure we protect our elective beds. So Faye mentioned earlier the really good news that we've been able to open up some dedicated orthopaedic beds at the Kettering site. We really need to make sure that we're protecting those beds over the coming months and we don't go into them with any non-elective emergencies to protect our waiting time recovery. There are also some opportunities that I'll just highlight though. One of that being is that we do have some strong relationships across the system, and we've got a really good process in place to work together to make the most of the capacity we have in the system. There is still some capacity in the system that we aren't using, and we are currently working up plans across the three kind of main providers of the independent sector, Northampton and Kettering, as to how we're going to make the most of that. So that will, if we can do that, that will be an upside further to the plan that we're submitting at the moment. And key to that really is developing a system PTL, a PTL being a patient tracking list, or what we would call or know as a waiting list. So traditionally, each organisation has their own patient waiting list, but what we're trying to do now across the system is bring those organisational waiting lists together. And the benefit of that is that we'll be able to then make sure that patients across the county get access to the capacity where it is, when it is, and we don't have patients waiting longer in one end of the county than we have in the other. So overall, that's really going to help. And the other reason that that's going to help, and our primary care colleagues are absolutely bought into this, is it will help our GPs firstly know where to refer the patients so that they have the least amount of waiting times. But secondly, that they'll be able to see what the waiting times are in each of the organisations, so they can help to support patients keeping well and safe for longer whilst they're on that waiting list. So our primary care colleagues are absolutely bought into that, and it's a really positive move actually. So Andy, our Chief Digital Information Officer, is working to set up that system PTL, and you might want to talk about that in a moment. So overall, two other things probably to note before I hand over to Faye. The first of which being that whilst our activity actual delivery is set to increase, the impact on our waiting times and our actual RTT and our backlogs is not fully known. And the reason why is because we don't as yet know what the latent demand still is. So the patients who haven't accessed their GP over the last year and who might be waiting or only just feeling confident enough to come forward. And nationally, they're predicting that that might get up to 120%, so 20% more of pre-COVID levels. So at the moment, we don't as yet know what that is. That isn't part of this planning submission, but it's something that we are going to need to keep an eye on, and we can come and update the board on our referral trajectories and our referral numbers as we go forward over the next few months. And I think the other thing to note, which I think Simon mentioned at the beginning, was that we have been asked to offer help to some of our neighbouring counties who aren't as fortunate as us in terms of their waiting times and aren't able to open up as much capacity as we're able to. So we have offered help, and some of that is starting to get taken up. So as that again may have a slightly different unknown effect on some of the activity numbers we have in here, if we're helping to prioritise some of those cancer patients, for example, and those urgent clinical cases that are actually out of county. But without further ado, I shall hand over to Faye, who can give a bit more of an update on the Kettering perspective of our activity plans. I think you're on mute, Faye.
Thank you, Polly. Okay, so from a KGH point of view, we have taken a very considered approach with our teams, and as Polly mentioned earlier, very much a bottom-up approach with our divisions, and likewise the divisions with the directorates. And we've had a series of confirm and challenge meetings, which I've chaired with Polly and Neil to really understand the position and the nuances across all of the specialties to make sure that our plans are robust. We've also considered the effects of annual leave. We're really keen that staff take their annual leave. It's really important to us that our staff feel supported and that we look after their well-being. So what we've done in our profiling is made sure that we've accounted for that within the submission. As we've talked about, though, there is a real tension between the activity and the staff that provide the services. And we are really aware that our theatre staff have been through the mill, I suppose, in terms of the last 12 months working in critical care. That said, they are really keen to get back into theatres and do what they love to do. So that's really positive news. However, we just need to be mindful that you know they're not keen to be doing additional activity, and we need to think about what other options are available to us. as agency staff are not really available to us at this moment in time. The second point or risk that we need to talk about, and Polly's already alluded to it, is the protection of our elective beds. We've worked really hard over the last few weeks to be able to put elective orthopaedics back into the hospital. So we really need to continue to focus on our discharge and flow programs, which we spoke about earlier. And these link really heavily into the ICAN program. We've also undertaken a full capacity and demand exercise. So we're really clear on what level of length of stay we need to be at in order to maintain that capacity and deliver our elective activity. So yes, we have opportunities, absolutely. We've got 2 theatres in the KGH which we're not able to staff at this moment in time due to staff vacancies. So we're in the process of working with a third-party provider to see if they can provide us with some theatre staff, and we've also started some conversations with the Wonderland Hospital to see if they've got any staff that we could that potentially could come over and support our team so we can deliver more activity. That's very much work in progress, but there is a keenness from the Woodlands to try and support us with that. And as Polly mentioned earlier, we're also working with other hospitals, and actually Northampton are looking to see whether they can also optimise and utilise some of our theatres. Another thing we need to really focus on is productivity across outpatients and across theatres. And we're in the process of setting up a weekly confirm and challenge meeting, looking at how we can utilise and ensure that we are effectively utilising all the capacity that's available to us. We're also aware of the GIRFT programme, and that we will be obviously engaging in the relaunch of that across the region. And my understanding is that there are 6 high volume, low complexity specialties that will be the focus. So we will really start to work with Polly as part of the elective care board to progress that work. So in answer to the question, are we being ambitious? I think we have a balanced plan at KGH that kind of makes sure we're looking after our staff. I think there are absolutely opportunities which we need to work through, but in my opinion, the submission that we have at the moment is realistic and achievable. I'll hand over to Mark. Thank you.
Thank you, Faye, and absolutely, I echo those points in terms of your summary. It's not a huge amount more for me to say other than that. Really, that it is an absolute balanced plan. Within the content of the pack, everybody has the information that we discussed at the People Committee earlier this week. I think some areas for us to challenge ourselves in and around, you can see from our system submission in relation to the National People Plan and indeed our Group People Plan, we are making and tracking good progress. There is still always more to do from that perspective. From this particular planning submission, however, we are really triangulating that balance of making sure that people have breaks, that have rest and that we're able to take leave over the summer period, but also balancing the needs of our patients and service users, which is a really challenging one given some of the waiting list that we may have. So there is investment within our plan, as you can see, as articulated within the paper. And I think a lot of the nervousness around that investment of individuals, centres or posts, centres in relation to if we are unable to recruit to those posts substantively, would we therefore use temporary staff at a premium rate, which would then therefore impact upon our financial performance and our financial situation. And we have been through the workforce stress test that you see within the pack, and we concluded that across the system on Wednesday afternoon. I'm pleased to say we had a number of, Anil and Paula attended that particular system meeting along with myself, where we really went through and challenged with system partners and colleagues, what can we do as a collective in relation to the investment that we need to make sure we can recruit to these positions, but equally, we're not taking people from one another organisation in order to suffice one particular part of the system's desires or planned achievements, if that makes sense. So there isn't a huge amount more to say other than I think it is a realistic plan. We have challenged ourselves hugely in terms of the posts that we are putting in, but equally the pay that we are putting in, acknowledging, as you can see in the finance report under the IGR, the waiting list initiative payments that we were making through April and will need to continue to make to reduce our backlogs. So there isn't a huge amount more I wish to discuss. The big element for us, as centred in the risks on the particular paper here, is What the plan doesn't take into account right now is whether we have a third or fourth wave, depending on how you count them, of COVID in the winter, and what significant impact that could have upon our staff. We know from a psychological perspective that one of the things that is causing the greatest anxiety in our workforce at the moment is how would we possibly cope with another winter like the one we just had? And therefore that's something for us to continue to monitor and work on, hopefully never to realise that position, but it's something we need to continue to work upon, particularly when we look at our retention numbers and those colleagues that we have that may be close to retirement or decide that they want to take an alternative career path. We need to keep those dialogues open with them, but we are doing so as we've already heard in earlier presentations. So I will stop there and hand over to Anil.
Thank you, Mark. So in terms of the financial position, in terms of that triangulation piece, what we've got is a fully bottom-up developed financial plan, which triangulates with the workforce and the activity. We do recognise, however, there was only one financial plan submitted, whilst the workforce and activity have been developed for a second submission being made. But we are ensuring that we triangulate that to make sure the financial plan takes that into account. In terms of we've been working as a group, so recognising that it's a system conversation around the financial plan. So the system position is a break-even return for H1, and each organisation within that, including ourselves, is submitting a break-even position. So effectively, that H1 plan reflects activity based on current baseline capacity and the workforce requirements, as per Mark's comments earlier. What it doesn't include is any increased referrals or activity based on the demand coming through that Polly mentioned a minute ago, and it doesn't include the impact of any potential third wave of COVID. So the other key assumptions within that are, we talked about ERF, Elective Recovery Fund. So within our break-even position, it does include £2.8 million worth of income being recovered, net of any costs that we might incur. But it is worth recognising that ERF, as Polly mentioned, is at system level, not organisational level. I touched on earlier an agency target for the year of 10.8 million. For H1, we have an agency spend cap of 5.5, and we have an efficiency target for the first half of the year of 3 million compared to the 7.5 for the full year. Now, obviously, the other thing we are a full year plan to get a longer term view of what our financial position is, and that's with our system partners. So we know we have an underlying deficit of 117 million, of which ourselves as a group is about 107. For KGH, that's about 53. Mark's just mentioned the key drivers of some of those, which is the pay and the workforce challenges we've received. So again, we need to justify and review all those investments we make around workforce and spend going forward. And again, NHSEI's view is that they'll be expecting a further improvement in that underlying position by circa 20 million going forward. So some of the key risks, we've talked about some of those just now. So some of the key risks in relation to the financial plan being delivered, along with the triangulation of workforce and activity, are the third wave of COVID, the workforce availability aligned to the plan that Mark's just mentioned, and also the delivery of the activity in order to recover that ERF income. And the other part is the efficiency savings, so making sure we can deliver those efficiencies that we've planned for the first half of the year and subsequently for the full year. So what we do need to ensure, and we are doing, is a clear financial strategy that takes into account the deliverables around our patients and the activity, our staff, and the financial position. What we are doing is reinstating workforce management meetings to ensure that recruitment drive is monitored and we manage our temporary staff usage, efficiency plans through a steering group to make sure we deliver those savings plans that we've identified. And we have weekly performance meetings to monitor the activity in order to make sure we deliver the activity we need to for the ERF income recovery. That's the financial position summary. Back to you, Chair.
Okay, thank you very much. That's mostly went through PF&R and other relevant committees during the week. So the questions are you happy we've got the balance right? Are you happy there's no incompatible ideas in this? Are you happy it fits with a long-term intention, if you can regard H2 as long-term? Trevor.
Thank you. Broadly, very positive. I think, these things are very fine balance, trying to say we're going to balance the workforce, the finance and the activity. Two questions. One is, what's the process around bringing in any activity from outside the patch? Recognising there's always been activity coming in from outside the patch to some extent, but if we're deliberately taking this decision to support cases coming in from outside the county, how are we doing that? And the second is around, whilst I think it was Faye mentioned the annual leave and making sure people took their annual leave. How do we make sure that that's managed? Because the number of times I've heard over many, many years, or we've suddenly had a whole load of people go off at the same time. Well, it's funny, the school holidays happen to fall at the same time. How are we going to make sure we manage those blips that actually can cause disproportionate disruption to patient activity? Thank you.
Okay, Lisa.
Thanks. My questions were around some of the items that were discussed. So I think it's a really good process, and I want to explore something that I think Polly mentioned, which was the ability of GPs to look at the waiting lists and wonder whether we think there's any risk, because our long waiting position is much better than our neighbouring trust part of the group, whether we think there'll be increased pressure on our consultants. And secondly, a question to Mark, which is the impact of the blocks on inward recruitment of nursing on our recruitment and our staffing position, and whether we think that's a major risk, and if so, how are we going to mitigate it?
Okay, no other comments up at the moment? You want to respond to those, Polly, Mark, whoever?
Yeah, I'm happy to start, and I can hand over to Mark. So on Trevor's question then about the out-of-county patients, so I think there's probably two routes in, Trevor. So the first route in, which is happening kind of already, and to some extent already did happen, which is actually consultants picking up the phone and speaking to each other. So that we have already across the group taken some patients from Leicester, for example, particularly on some of the cancer pathways. And I believe also in some of the teledermatology Northampton have been helping with. So those networks, those clinical networks already exist in terms of those tertiary referrals and work. So there has been some movement back with some of the patients, and they've been supporting us, for example, to try and do some of the more specialist work to help with that. So that's the informal route, if you like, or the clinical network route. What we're trying to do, though, Trevor, is actually try and get a hold of this at system level. So to make sure that any kind of formal requests are coming through the System Elective Care Board, and they should be approved also by the region. So there is a more formal route that some of these requests should be going through. What we're trying to do is work with the region and with some of those other trusts to strengthen that more formal route, to make sure that as a system we are fully aware, number one, of what is actually happening at the ground, and therefore, number two, can take whatever decisions we need to take on balancing the risk and how we're going to organise ourselves and the impact on our patients locally with some of those agreements. So we're trying to make it more formal than it currently is. On Lisa's question, which I've temporarily forgotten, Lisa, I'll come back to you. I'll let Mark answer first while I remember what your question.
It's about waiting times, Polly, and pressure on consultants as we move to...
Oh, that's right. Yeah, thank you for the reminder. Yes, so it's about the system PTL, wasn't it? So yes, in answer to your question, yes, there is a risk that our Kettering waiting times could start to get longer in certain specialties if we're balancing out waiting times across the county. So yes, that's a risk, but as Simon alluded to in his update at the beginning, and about CPC, we have started work on the group clinical strategy. So as we move forward over the next few months anyway, we will be working together and working at single acute services that are working across the county. So regardless of working on the system PTL, we would be looking to do that anyway, because our clinical teams are coming together in that clinical strategy and working out how we support patients across the county that need acute care, rather than just specifically in local areas. So yes, it will, but we would be doing that anyway.
You are, of course, right to raise the question, because as you move away from payment by results, you break the connection between activity and income. And therefore you need to think about a different way of handling that. And for those of us who've been in the health service for a long time, things like extra contractual referrals will start to reappear because people will start to think about how we handle borders and boundaries. So it is worth quite a bit of thought about how you align the financial incentives. It's easy enough across the group. Well, it's not easy, but at least it's feasible across the group. And we've always talked about trying to remove the barriers that finance put in the way of patients moving between the two. But it is much more difficult as you start to move into a non-payment by results model. Not so bad this year because we get ERF funds and other monies for hitting numbers, but quite quickly that problem will begin to become real. I'll come to Mark and I'll come back to Debbie. Mark, on the sort of Indian variant and the block on international recruitment, I think is really the question.
Yeah, no, and it's a fantastic question, Lee. Thank you. And it was something that I completely didn't talk about in my update in terms of our big driver, in terms of our vacancy reduction position, both from what we have at the moment, and indeed with the additional investment is around international recruitment, particularly of our nurses. As you can see, it's our largest increase in workforce across both KGH, NGH, and indeed across the system with NHFT also. So it's a huge impact. However, we have been very successful to date. Every international nurse that we have expected to receive has been received in the organisation and thankfully have started work and is customising themselves to working within the health service. We have reprofiled our international nurse recruitment in terms of understanding and understanding the position worldwide, particularly as we've discussed in India at the moment, in terms of colleagues not being able to join us from that particular country. The risk will obviously become greater the longer that continues. If it's fair to say, it's the longer or more widespread that could become across the country or indeed the world. That becomes more of an issue for us in relation to international nurse recruitment. So in simplistic terms at the moment, not so much of an issue. As we go into later into the year, we do have a number of colleagues that were due to join us from India. And if that's not possible, that will put further risks into our plan. One of the big things for us also at the moment that I obviously again didn't mention because of the 21-22 submission is working with our local education authorities to make sure that we are not solely and continuously dependent on international nurse recruitment or indeed international recruitment per se, but we also have a stream coming through in terms of supply for our domestic recruitment to nursing positions. And that's really important, but also what do we ask those education providers to educate our nurses on? And that will be based on models of care and so on and so forth. You know, ICANN being one that we could use as an example. So from an international nurse recruitment perspective, it is a risk, absolutely. It is not as much of a risk just yet, but it could become greater as the year progresses. In terms of the question, Trevor, around annual leave, you're totally right. I think when I look back on the planning submission for 21-22, it has pleased me no end that we took the decision that we did again across the group to allow colleagues to carry over a certain amount of leave, but also to allow colleagues to be paid out a certain amount of annual leave. Now, we did that because that's what colleagues asked for, but also had we have allowed colleagues to carry over significantly more proportions of annual leave, we would be in a more challenged position, I believe, not just this year, but indeed next, because we'd be rolling over so much annual leave from one financial year to the next. In terms of making sure August, which is always the month, as you know, as we've been in the NHS, we always know August is the month where activity drops through the floor because we say, oh, everyone's gone away. From an operational perspective, we need to just keep tight and manage that. And we have better systems in place to do that now with our roster in. We can see it almost at the touch of a button. I know annual leave in April was low, and we could argue that's because also people's restrictions and where people could go and so on and so forth. We have seen it grow through month 2 or this month of May, but we need to make sure that it doesn't exceed the tolerated levels of 13, 14, 15% in the months of July and August. So we are actively onto that, and we need to manage it at a local level.
Thank you, Mark. I'm going to Debbie now. Lisa, I presume that's an old hand. Debbie.
Thank you. So firstly, thank you to Polly, Anil, Faye and Leanne for the huge amount of work that you've put into this. But actually, it's been a collective effort from the exec team. We've spent quite a bit of time on the plan together. So I think in terms of your questions, Polly, is it ambitious enough and are we being realistic? So we've definitely got a duty of care to look after our staff, but equally we have got patients who need us. So we will, that's a fine balance, and we will need to balance both of those together quite well. How do we manage tensions? So as a group, safety first. But what comes with that is the health and well-being of our staff, to make sure that we are practicing and operating in a safe environment, and what we are doing is safe. I think that's fine for H1. Very similar story for H2, but of course we know that there will be many variables. And we don't quite know yet what winter is going to look like, apart from it is likely to be challenging. So the governance that we have strengthened around this will help us as we go through the next few months, in terms of knowing how our staff are through some of the listening events, knowing how the activity is going through the recovery groups, and we'll be able to update the committees of the board and the board as we go along. Thanks, Chair.
Okay, thank you. I'm not seeing any other hands now. So Simon, over to you.
Thanks, Alan. I just wanted to return to Lisa's question and about system PTL, which I think this is a moment when we move from something that we would have thought about in digital terms over probably quite an extended period of time, to something that we really now need to think about urgently, because it's going to be essential in terms of managing the risk across both the increased demand and treating the patients who are on our waiting list. And the truth is, at the moment, Lisa, we don't have such a system PTL in place. We don't have that technology. So I thought it might be helpful if Andy just gave a little bit of a flavour of what's going on in terms of the development work he's doing on that, because he's now also the system digital lead, but also to suggest to Alice that the Digital Hospital Committee starts to pick this up, because getting this in place, and us collectively, not just as hospitals, but a Northants system, understanding our PTL and how we can respond to it, I think is going to need to be the new normal, far quicker than we might have thought it would be pre-pandemic. It was something that was coming, but now we really need to get on with it. So Andy, if I could maybe come to you just to say the work that you're doing, and then hopefully, Lisa, you'll get a flavour of some of the issues that are in play for us to be able to deliver this.
Yeah, thanks, Simon. So I think probably the first thing to say is there's been a bit of a journey of discovery as we've looked at this. So I think initially it was looked at, well, you know, is this a data issue where we can just use one of our data warehouses to do this? But once you get into it, the complexity of transferring patients around and having that visibility soon means actually it requires a lot more heavy lifting. We've had the teams looking at 4 different solutions, and there's various pros and cons of them. So what we're putting together a business case in order to put that in action. I think the other thing to note is that I've been reaching out across nationally to see what other ICSs are doing, and you know, probably it'd be no surprise to say there is no one picture, but you know, seeking to sort of learn from what other people are doing. But as Simon said, this has been, you know, needs to be done quickly because of the impact it could potentially have on making sure patients get the care they need most efficiently.
Okay, thank you for that. It's yes, I mean, these changes sound simple, but they are actually incredibly complicated to deliver in an equitable manner, equitable to the provider and equitable to the patient. It's hard to deny the fact that patients shouldn't have a longer waiting time if they come from Corbridge than if they come from Toaster. So, or indeed anywhere else. So, but it is an interesting question for a board whose responsibility is the waiting list in their own hospital and the finances of their own hospital. So all the things we've talked about how you act as a board for this hospital whilst being part of an integrated care system, all the models we have about system finances, all come crashing up against a wall of both individual board responsibilities and indeed our governors' individual responsibilities and attitudes. So these are difficult questions. Right, I don't see anything else. I think just to say that NGH approved a plan yesterday in their board meeting, So I can now take it that the board is approving the plans for the first 6 months of the year up to H1, and we'll all come back to look at H2. We notice all the commitments made by the various directors who presented these plans, Faye, Mark, Neil, and Polly, and we'll come back to remind you about those from time to time over the next period. So thank you very much to everyone. I think it is a good plan. Everybody said that, and we're not going to repeat that. It's been a lot of work gone into it, and striking that balance is very difficult. Okay, it's now 10 to 12, and you're due a break at 12 o'clock. We'll take the break now, and we will be back at 12 o'clock, please. And thank you very much. See you again. See you all in 10 minutes. Okay, 12 o'clock. Welcome back, everybody. Yeah, always good to see people snacking. Anyway, board assurance framework. Richard.
Thank you, Alan, and good afternoon, everybody. Sun's still shining down here in Kettering. So 4 things to bring your attention to regarding the board assurance framework. The first is that BAF 010, which relates to the board's preparation and response to the COVID-19 pandemic, has been rescored from a significant to still a high risk. And within that, the board are aware that we have a high level COVID risk register, which has a number of specific risks akin to corporate risks relating to our response to the pandemic. I've agreed with the Quality and Safety Committee that we will do a comprehensive review of all of the risks on that, but just to bring the board's attention to the fact that risk 12 on the COVID high level risk register, which is to do with the impact on staff, has increased from high to significant, predominantly to reflect the chronic impact on staff and the amount of work that Mark, Paula and team are doing to support our staff across the organisation as we begin to recover from the impacts of the pandemic. Thirdly, this is the last time the board will see the BAF in its current guise, both in format and in content. We're doing a lot of work with Northampton and within the Collaboration Programme Committee, as alluded to earlier on in the meeting by Simon, to align risks to the group priorities and the group strategic initiatives. And then finally, as part of that, and referring back to the planning piece we've just been discussing, we will be looking at how we curate a risk at group level to do with half year 1 and specifically half year 2 uncertainty around the finances and the, at the moment, lack of clarity and direction that we have around that. So with that, I will stop talking and open to any questions on the board assurance framework.
Okay, it's good to see a nice dynamic, up-to-date board assurance framework, and I note the comments you're making about aligning them with the priorities and aligning them with the way they're reported in NGH. Alice.
Thank you, Richard. Yeah, and I agree. I like to see them aligned to the group priorities, and then I also pleased to see the risk appetite coming in there. And it's a comment, therefore, really rather than a question. It's around sort of BAF 6, really, but it could apply to some others potentially. I understand why we've put that in systems and partnerships, and therefore we've got a high risk appetite against that, as we talked about at our last discussion on risk appetites. But it feels like there's a big interaction there with patient experience and patient quality, for which we've got a low interaction, a low risk appetite. So it's just a sort of question, I guess, as to how we're going to deal with those intersections where we have an issue potentially.
Yeah, I think that's really interesting, isn't it? So BAF 6, for anyone who hasn't rushed to it in their pack, is all to do with out of hospital capacity and the impact on flow and capacity within the hospital. So good comment, Alice. We'll take that into account and look at that in the context of how we review the BAF going forward, which we'll see again in July, as I said.
Yeah, it's clearly the case, Alice, that, you know, as we talked about in the plan, it's all very well bringing down our stranded and super stranded, but they're still nearly twice what they ought to be. And, you know, the ICANN program is moving forward, but you can't put all your eggs in one particular basket. These are all about other relationships and so on. So, and there's no doubt we will be a much more efficient, effective and productive hospital if those systems work properly. So they all link together, and it is I always like what Richard thinks is an interesting question, but it is an interesting question in this case about how we hold these risks together. So any other comments? No? No, thank you very much, Richard. It is, it's good stuff. And I know your comment about H2 having a big risk around group finances. But it'll be interesting to see the outcome of your work on the group risks and the aligning the way of presentation with NGH. Right, nursing, midwifery and allied health professional strategy. Leanne's no doubt presenting this. We've talked about it in the board before in development sessions and in other areas in the people committee and so on. But remembering 3,000 nurses and a load more allied health professionals, getting near to 4. That's an awful lot of people to be covered by this strategy. And it fits in very tightly with our academic strategy and our people strategy. So Leanne, over to you.
Thank you, Chair, and thanks everybody for allowing me to share this today. Again, in terms of obviously following up from the board development session that we spent some time looking at this and getting some feedback and comments from everybody. So it's absolutely right and proper. And as Alan said, we have the largest workforce across both organisations, and that is unlikely to change. Whilst this paper may say currently, that is unlikely to change in the near future. We may see some of those roles emerge, change, blur, but nonetheless, they are still likely to be the largest workforce. And the contribution of this group to the clinical strategy, all our HIP2 work, the ICS group, etc., is absolutely written throughout all of this. So it's right and proper that we have a strategy that articulates the voice of the vast majority of our organisations. I think we've said before, in terms of igniting the voice for our staff, that we've had over 1,000 nurses, midwives and allied health professionals actually contribute to this. So this is fundamentally their work. And Sharon and I have very much taken that and obviously published that in relation to this document. So I think it'd be really great to hear from people if you feel that we are on the right tracks. What has been included this time is our clear objectives for the next 12 months. However, we have made some further tweaks to that to make them far more smart and more robust in terms of our outcome measures. So I'm happy to go into more detail regarding that. So if I just pull 1 or 2 out from there, it might just help so you can see where we are going. And from a KGH point of view, what I'm really proud to say is that we're actually moving now into having our own Deputy Director of Midwifery. So that post is out to advert, and also a Deputy Director for Allied Health Professionals to make sure that we've got parity at a corporate level with the strategy and that we can start to work and more closely align with the work at NGH. And I'm sure in time that will lead on to some more group roles. So in terms of the strategic delivery for 21-22, our key kind of aspects for this really are making sure that from a safety and quality perspective that we establish a joint approach to patient and family involvement groups. Now, obviously this closely aligns to the group strategy dedicated to excellent patient pathway work. And what we will be doing is releasing time for our patient experience managers to look across patient pathway to truly understand exactly what's happening to patients along their journeys. We think we know, but we don't necessarily know all the nuances, and it's right that we tackle the kind of root causes, things that they're feeding back to us. We absolutely need to benchmark and align at least 5 of our key quality metrics, including improvement trajectories, method of achievement, method of reporting, so that we can start to benchmark more effectively. So for example, falls, pressure tissue damage, that may well be. And that also supports us in the work that we're doing across the Quality and Safety Committee as a joint committee in common. So they're the kind of key objectives, those 2 high level ones for our safety and quality care. In terms of leadership, we are absolutely going to focus on our equality and diversity agenda. Conversation we had with Simon last week is, absolutely writ large. We know now that with a number of international recruits to the organisation, the way that we have to work, the way that we have to communicate, not have to, need to, is changing. And we absolutely need to be on the front foot of that and to really understand what those differences in the workforce need. We will support at least 6 staff onto fellowship development programs, and that will run across both NGH and KGH. And this is in essence a chief nurse post that supports staff in practice to undertake academic projects. And that actually represents about 200% of our organisation. So in 2021. 33% of staff at band 7 or above will have completed a leadership programme. Now, what we will be doing in this space is putting some numbers to it, because that might not sound like a lot, but it is a lot of staff. And we will establish unconscious bias training. So I won't go through every single piece of this, but what you have in your pack is a trajectory for the year in terms of our objectives. And what I've said is we're starting to think about how we make those smarter, how we include numbers so it's very evident where we are making improvements and where we aren't. And all of this will report obviously through to our individual nursing boards, but it will also feed across the joint nursing midwifery allied health professional group and into our Quality and Safety Committee, because that is now jointly and in common. So I am now really excited that we've got to this point. I think having spent some time with the heads of nursing, midwifery and allied health professionals yesterday, and Debbie and Paula got a bit of a grilling from them, but and along with Ian, but I'm sure they welcome that, about how do we now take this and deliver it. We talked a little bit earlier about the role of the ward sister. We've absolutely got to focus on that. It's a role that's become completely multi-layered, and actually we need to make sure that we have people in post that can function effectively, and this strategy helps us to do that, and allows us to use some of the digital work to take that further forward. I'll stop there, Alan, but I'm happy to take any questions on this, and please, feel free to challenge me if you think we've not been ambitious enough, or you think that the objectives we're setting for the first year could be better or different. That'd be great. Thank you.
Okay, thank you, Leanne. I know a lot of work's gone into this. Andy.
Yeah, I just welcome this and just want to thank Leanne and team for responding to some of the comments that were made around equality and diversity last time. I think the stuff here and how it's linking into the fabulous Building Cultural Bridges programme is going to be absolutely amazing, because I think it goes beyond just an unconscious bias questionnaire into actually having real discussions around how we have uncomfortable conversations about race. So thanks, Leanne.
Thank you.
Chris and then Lisa, please.
Thank you. So really good strategy from my perspective, which I strongly support. But I was just asking, this is a group strategy. What is the group doing with the schools of Northamptonshire to stimulate and encourage local recruitment to the NHS in the broadest sense? Because it seems to me that a lot of schools do not understand how good an organisation the NHS is to work for.
Thank you, Chris. That's a really, really valuable question. So whilst we haven't done over the last 18 months, we have historically spent quite a lot of time within schools, and certainly our education team have put on kind of come and try days where they've looked at using mannequins, the sim lab, etc., to try and encourage people to think about how exciting a career in healthcare might be. And there's also a national programme about conversations in terms of clinical practice, whereby people like myself will go to virtual forums now and start talking about our life journey and what it's meant to us in terms of the professional. And we are seeing more staff coming forward into nursing and midwifery and allied health professionals. The challenge for us as an organisation and through this strategy is to make sure that we've got enough placement capacity, that we have enough mentors, that we're thinking differently about what kind of placements might look like for different parts of our society, and be as creative as we possibly can be in that space. Because it's actually, when you think from a ward perspective, with international recruits, student nurses that are there already, allied health professionals, assistant practitioners, etc., we have to think differently now about how we do that. But it's a very valid question, and we absolutely need to be out there with our voice.
Lisa and then Andrew.
Nice. Leanne, you and I discussed at a recent maternity safety champions meeting the disparity that there was in the funding of homegrown recruits versus international recruits into the hospital who have committed to us for a significant period of time in terms of the funding. Those of you who don't know, there's a markedly different level of fees that the universities wish to charge us. Are there any other kind of organisations that take a different view that kind of could undermine what we're trying to do, which is a culturally fair and appropriate approach to our professional development?
Thank you, Lise. And yeah, we absolutely had that conversation, and that did come up through our maternity safety meeting, whereby, for those that don't know, and I actually didn't know until this point, is that our international nurses that are applying to do the quality programme related to neonatal practice are essentially being charged double the tariff as to a native student, and even though they're members of the workforce in the country. So I have put out feelers to see where that's come from and what we might do about that going forward from a national point of view, because it's actually not, it's absolutely not what's the word, disparitus, if that's a word. And it is definitely not equitable, and it's definitely not fair. And it's a bit appalling that from a national perspective, that's where we find ourselves. But you're right, maybe we need to have our ears open to other things that are coming about in relation to that. Thank you.
Thanks, Leah.
I've raised it at regional level already.
Okay. It's really a pretty unhelpful place to be, isn't it? And I mean, we absolutely commit to giving our international recruits every opportunity to move onwards. They've committed to coming here, and that's well, yes, you made your point, ladies. Andrew, and then Janet.
Just a quick comment, Chris. Over the years, I've been attending the Northamptonshire schools to talk to them about careers in the NHS. And I have emphasized careers in the NHS because it's such a broad church. And I've normally taken someone from me, sometimes from estates, sometimes from finance, nursing, specialist nursing, to give people a flavor of opportunity around that. It's clearly been there's been a hiatus since COVID's on, but maybe it's something I need to formalize a little better and to get greater coverage, because it is a rich seam, isn't it?
Janet.
Thank you. I just want to echo a really positive thanks for this tremendous piece of work. It's had a good sounding at the Workforce Committee, and I think is evidence of a joint piece of work between the professions. I think it's excellent and really great engagement. So thank you very much, Leanne.
Thank you, Janet. It's really helpful. And obviously we've got work to do on the healthcare scientist part as well, but thank you. Yeah.
Simon.
Just wanted to, on behalf of us all, thank Leanne and Sharon for the work that they've done to get this. I think we can safely say with over 1,000 people contributing to it, it's genuinely representative of the voices of the people who we're trying to help and serve. One thing I just want to draw out is that conversation around diversity. I challenged Sharon and Leanne about how many of our very senior nurses came from BAME communities, and I think the answer is probably not as we would wish it to be. And I think we've got challenges that I think various committees will need to pick up in the year ahead about the diversity of our nursing leadership at ward, and particularly at head of nursing and deputy level, that I think will be important for us to be able to really make good on the pledges that you've rightly called out, Leanne, around diversity. But overall, I really want to commend this to the board and say I think it's a really important and timely piece of work, coming as it does at the end of the pandemic, when we will really be going back out into the market again and out to try and show that we are the place to come and work. So thank you very much.
Thank you all for your support. Thank you.
Yeah, okay. Thanks, everybody. It is a good piece of work. Proof of the pudding in the eating and all that. It's about delivery of all the things it's committing to in year 1 and year 2 and year 3. And it is important, people say to me sometimes, we've got strategies coming out of our ears. And we do have a lot of strategies. Of course we do, because we have a lot of problems to solve. And the art form is to make sure those strategies are compatible, that they're in an order. There is a hierarchy to them, of course there is, but that they do fit together coherently and that they are mutually dependent. So it's all beginning to look good. The other thing to think about, of course, is it's the board's job to think 5 and 10 years ahead. So when we start to see these strategies, yes, it's necessary to think about year 1 and year 2, but we're also committing to a long-term direction of travel here. And that's another important thing to bear in mind, Leanne, that this is a long-term direction of travel. And you will find you bounce off a few rocks on the way with this, but the success is measured in the long term. Okay, there is actually a very specific question, I think, about Pathways to Excellence board accreditation in the chat. Who would like to answer that? Would you just, the whole business of Pathways to Excellence linking to our current board accreditation pathways?
Sorry, I didn't see the question, so let me just have a look. How does the Pathways to Excellence link to the ward accreditation we have in place? Yes, so thank you, really good question. So Pathways to Excellence is essentially a framework by which we demonstrate or evidence practice that could be around leadership, it could be around quality, it could be around staffing, it could be around attitude, culture, etc. So in essence, a bit like a CQC kind of core service framework. Ward accreditation is one aspect of that allows us to articulate and measure effectively what, for example, all our quality metrics are saying to us. So it's only one aspect of the pathway to excellence. Does that make sense? Thank you. You're on mute, Alan.
Yes, it does. Thank you for that. Right. Okay. I think we're, sorry, very well. I'm clicking the right button at the moment on my side. Right. Thank you very much, everybody. You can take that as approved. I think we're all impressed by the work that's gone into it, Leanne, and we now expect you and your nurses to set about delivering it. Thank you very much for that. I don't see Dr. Bilalicker here on the attendance yet, so I'm going to jump to.
Alan is in the lobby, I understand.
Oh, is he? Okay, well.
He's just joining now.
Okay, thank you very much.
Lise, would you mind muting yourself? I think your line is causing a bit of blowback. Thank you so much.
Dr. Bilalicker, are you there? Yes, you are. Thank you very much. Thank you for coming. We are running a little bit ahead of schedule today, so you're on early. If you're ready, would you like to give us your Guardian of Safe Working Q4 and annual reports? And I think we all recognise the stresses and strains of COVID, both on the training programme and on the junior doctors, and how to fit the two together and so on. But please give us your report on where we stand at the moment.
Harsha, unfortunately, we can't hear you at the moment. I don't know if you've got your Zoom configuration set up for the right microphone at the moment. Sorry, Harsha.
Yeah, no, I am trying to.
Here we are. Yeah, we can hear you now. Thank you.
Yeah, okay. Yeah. So this is the annual report for the period 2020 to 21. I have also included the last quarter from December to April of this year in the same report. Essentially, exceptions have actually been less than the previous year, particularly in the active quarter from April to August, and thereafter August to December, there were quite a few less than what we normally saw. And then they have gone up from December in the last 4 months. That is possibly because of the return. They mainly came from surgery in the last 4 months, and they probably relate to a change in work pattern, because the ward-based working had to be put in place instead of team-based working, meaning that the direct line of command from F1 to SHO to registrar to consultant was not there. People were working in wards with different teams, which was a new way of working. We did have quite a lot of discussions with the surgical consultants who were responsible for the rota, but that bit was quite essential because of the requirement to segregate wards in green and red areas. So that led to a bit of a problem, but and then also similarly, urology trainees were put in surgery, and that caused a bit of the blip in the exceptions. Yeah, next one, please. Yeah. Essentially, rotas were changed to the nationally approved changes from April to August, and by August we went back to the normal rotas, meaning the rotas that were in operation before April. As I've already mentioned, problems came in because of the team-based working and urology trainees working in surgery. This has now stabilized over the last 2 to 3 this has now stabilized. So from sort of February onwards, it stabilized. One of the positives that came out of the year was that the medicine rota has stabilized. So these were the changes that were brought in following the change rota from April 20, and they came out to be quite beneficial, and they've now become regularized. So we perhaps are seeing less of a blip in the number of exceptions from medicine. It would be interesting to see over the next year or so whether that also translates in a reduction in locum requirements, and that would be something to see for the future, whether that turns out that way. There was a change in the rotas for pediatrics and A&E with 1 in 3 weekend rotas. So this is the recommendation that came out of the new junior doctors contract, meaning the now mutually agreed contract between the junior doctors and the Department of Health, whereby the 1 in 2.6 or 1 in 2.5 rotas were not legal. And this change has been implemented in pediatrics and A&E. So we are more or less, we have managed to implement the changes that were required following the mutually agreed contract, as opposed to the previous acrimonious imposition of contract. So we, as a trust, we are okay with that one now, along with the rest and recovery facilities. Next one, please. There has been an unusual locum requirement in obs and gynae, which was possibly because of a degree of understaffing. Now it's fully staffed now, so hopefully that will come down. Restrooms for urology, again, they've now gone back to their previous pattern of working. And one thing that's probably not coming across very well here is that the urology exceptions have reduced, and that might be directly potentially linked to the recruitment of urology nurse practitioners. There is better support on the ward for the F1s in urology. Restrooms for junior doctors are operational. There were hotel facilities also put in place, particularly during the COVID period. So that was really well managed within the trust. There has been some degree of utilization of the restrooms by people who potentially didn't need to use that, and that would be something to monitor in the coming year. The Junior Doctors Forum has been very active. Very active is probably the wrong word, has been active. However, with move on to the online forum, attendance has been markedly less. One thing was noted was that part of the reason for the increased locum and work might just have been due to self-isolation and sickness. So some degree of locum requirement also is coming out of self-isolation and sickness, and perhaps linked to work intensity. I think most of the junior doctors rose to the occasion rather well. There was a lot of public goodwill and support, certainly in the first lockdown, and the trust provided excellent support with a very visible executive team, and that was very well received. Can we move on, please? Yeah. So essentially, it's for the, in summary, the most of them still remain hours related. However, many of the rotas have been addressed. So A&E, pediatrics, medicine, urology, lots of progress has occurred. It has been a difficult but formative year for many. Formative in a sense that it's hopefully it's a one in a lifetime experience. Nobody wants to have it again, but it does lead to some development of character. It will probably have an impact on training, because there are a group of junior doctors who have only been in medicine in the COVID period, have never seen medicine outside COVID, the F1s who started in that time. So how is that going to impact for the future? Managing the pressures of catch-up work and managing the return to normal is going to be an issue. Kettering General has signed up to the Midlands Charter for Wellbeing, which basically the key points of it is that there needs to be adequate experience, there needs to be educational support, and there needs to be a training environment. Currently the experience is kind of has been skewed towards COVID and COVID related stuff, and to return to the normality. So adequate experience, which even in the non-core areas, educational support, and to make a training environment with a good backup, rest and recreation, flexibility around rotas. So Dr. Das, who's the Deputy DME, is leading on this one. And there have been a number of people signed up. Hopefully that might go some way towards making the junior doctors feel valued. One of the things I wanted to bring up was that on previous annual reports, I had a couple of years brought up the issue of trust grade doctors. I think we have made quite good progress on that one. The trust grade doctors are now on the same contract as the doctors in training. So this is in the long term certainly going to be beneficial for the trust. Increasingly, the proportion, there is going to be an increased requirement of trust grade doctors, and to have two groups of doctors doing the same work to be treated the same way would be the right direction of travel. So that is again, this is something that would need to be kept in mind, may not necessarily only be from the hours point of view, but from their education and training perspective as well. As mentioned earlier, I would have thought that the impact of medicine rota changes on locum requirement would be reasonable to assess that, and also whether fatigue rooms are utilized for the purpose they are meant for use for at all times. So that's, yeah, thank you.
Thank you very much. Thank you very much, Dr. Billica. Any comments on the report from the Richard?
Just a question, Harsha, thank you very much for your detailed report and your fantastic explanation and presentation. As always, broad, but also right into the detail and telling us what we need to know. It has been a formative year for the trainees and for everybody in the hospital. But if you could use maybe 2 or 3 words to describe, because you're in a unique position connecting with our trainees, if you could use 2 or 3 words to describe how they are, what would those words be?
I think it's the, oh God, that's a bit difficult one. I think
Sorry.
how they are. I think there is perhaps a sense of resignation there. People are resigned to living through it for a few more months, and the people are also hopeful that things will return to normal. And certainly in the trust, they do feel that the trust is approachable and it can be addressed. And I would particularly want to take this opportunity to thank Andrew Chilton for, I know it's probably he's stepping down as medical director, and he has been massively supportive to the junior doctors to make sure that their requirements are always, he's always in mind, attending the Junior Doctors Forum regularly, taking a lead on it. And particularly, and also for me, I've always had full support from him whenever I have required that. But I think the junior doctors generally in this trust are, I would have thought they are probably in a better place than many other trusts. That much I feel so, yeah.
Thank you.
Okay, thank you. Chris and then Lisa.
Thank you, Alan. Harsha, first of all, thank you very much for a really excellent report. Just one question. You say number of doctors in training, 166. Does that include the trust grade doctors or not? And if it doesn't,
no, this doesn't include.
How many trust grade doctors are there?
Oh, the 166 does not include the trust grade doctors. In fact, one of the things I have asked medical staffing to look at is to actually make sure that we keep our numbers for doctors in training and the trust grade doctors up to date. So I'm sorry, I don't have a figure at hand as to how many trust grade doctors there are in the trust. So that is something I can provide in the next quarter report or in between if required, but I don't have at hand.
But safe to say, without them, we would sink.
I think it's safe to say that the expansion in the rotas, in pediatrics, certainly in pediatrics, potentially in A&E, and the increased medical, all that would only be possible with the trust grade doctors. I think, yeah, very much so. And at various levels, not just at the first on-call level, at the middle grade level as well.
Thank you, guys. Lisa.
Yeah, Harsha, again, thank you for a great report. Just a general query for me. What's happening to the trainee whose training got kind of hijacked by COVID? I'm just thinking of the surgical specialties. And what happens to those kind of people at the start of their career?
I think I think one of the issues in the Midlands Charter is to make sure that the training returns to normal, and the opportunities in training provided are not. So there are two aspects. One is what you have to do as part of your annual record of career progression. So that is something that is mandatory. And then there are the other things which you have to do to learn to do what you are going to be doing. And there is a focus on being able to do, enable trainees to be able to do both of these. I think from a surgery perspective, I am aware, though not directly in any way involved, I am aware that a lot of elective surgery work is happening under the NHS in the private sector. And that does, so over time, I think there may be a direction that the trust needs to look at whether trainees, they may be doing that, but whether trainees go there and do the because otherwise you will only be trained as an emergency doctor with very little elective surgical experience. And the same can happen to medics as well, but much more so in the surgery. So I think I will flag this up to Rob Preston to this particular query to how to address that, and also to the surgical tutor.
Thank you. All very good points, Harsha. Andrew.
It's just really in response to Lisa's question. So certainly the pandemic collided with training as usual, but it provided different opportunities and different skills. I think the best thing for the health and well-being of our craft-based trainees is to get them back into the theatres operating and functioning, and they know that, and our consultants are very aware of that, and they're looking forward to the reset on the basis of that. We didn't pause all activity. Our P1, P2 activity continued, and cancer surgery was preserved and happened at the Woodlands. And some of our middle grade, our specialty grade trainees were certainly operating and assisting down there. So it wasn't all loss, but certainly opportunity was diminished. But that catch up will happen.
Thank you, Rabia.
Thank you, Chair. Sorry, it took me a bit of a while to get my hands up. To answer Chris's question, Chris, on the number of non-training grade doctors, that actually fluctuates by the day, believe it or not. But from the last time I saw it, I think last week it was around 170. So that is the number, and absolutely agree with you. That is our big pool of very valuable talent. So one of the things we've actually now I'm looking at with DME Rob Preston is how we can actually make the route to consultant appointments for the non-training grade doctors, which is a CSER route, which is, I think, certificate of eligibility for specialist registration for them who are in non-training post, and make our trust and group as actually to be in the forefront to make it possible for those doctors, so we can attract them to stay with us, because we train them and then they leave. So we're just going to see how we can make CSER more. So we're kind of currently working on that framework, hopefully something that can be applied from next year.
Thank you, Rabia.
Okay, thank you, everyone. Certainly in my conversations with staff, the general but not quite universal view is for those specialties like that are surgical and in theatres and so on, the best therapy would be getting back to doing what they do. I just counsel it's not quite a universal view. So again, we just have to be slightly thoughtful about that, but it is certainly the majority view. Thank you, Harsha. That's an excellent report, and the board will no doubt adopt it, and look forward to receiving your next one.
Thank you so much. Thank you.
Thank you. Okay, annual self-certification. I get accused every year of forgetting about this and saying we don't normally do this, do we? And Richard tells me, yes, we do every year. So here it is every year. It has been approved by the audit committee, and can I presume you're happy that we sign the self-certification? Yes, good. Thank you very much. Group risk appetite statement, Richard. Perhaps you could talk a little about this, because I think it becomes. I think what we're trying to achieve here, apart from the changes in the risk register and the BAF, is finding a way to directly link some of our decisions to our risk appetite. So would you just like to talk about this a little bit?
Sure. So board members will recall at our last board development session, we had quite possibly in my career, the most in-depth conversation, A, about risk and B, about risk appetite, not just here, but in any organisation. We went through 2 rounds of scoring, discussion, rediscussion and rescoring to agree the risk appetite statements across our 5 group priorities, which were agreed at Northampton yesterday. This will make a significant difference in terms of us being able to pivot all of our risk management activity towards delivering the group priorities, both here and at Northampton. And that alignment that Alice talked about that's happening in the Digital Hospital Committee, and that understanding, we're going to have to go through a few cycles and a few churns of what does this mean? What does that mean? How do we reconcile them together and get to a place where we have a composite suite of risks, both in each hospital and between them at the group level, but everything orientated to the group priorities. And this is key to achieving that. At Kettering, we've reported risk appetite as part of the board assurance framework for quite some time. But I think what we need to get better at, and what we need to do together with Northampton's committees, is to actually understand, okay, so this risk poses this level of risk to us in the scoring. Does that exceed or not exceed our risk appetite statement? And then you can start to make those decisions and say, okay, well, we're clearly not doing enough in this space because we're exceeding our risk appetite. When we come to make decisions, we need to start to think about what risk does it pose. And risk in an ideal world is also about opportunity, not just negative impact. And we need to start thinking about that as well, because as a group and as a system, we're going to start making some really big decisions across the next year. And so by always referring back to what is our risk appetite across our 5 group priority domains, we will be able to do a bit more of that, which is really what it's all about, and something that I think most people in my position working in the NHS have struggled to get to, and I think we're actually quite close to it. You're on mute, Alan.
Thank you very much, Richard. Rabia, could I ask you to go on mute? I can hear you breathing, which is reassuring, but not entirely helpful. Thank you. Okay, I think we have come a long way with this, and I occasionally get a bit flippant about these things, but they are crucial to how we think about taking forwards and balancing risk in the board assurance framework. So, does anybody have any comments on the paper's contents? There are a number of things in it that you might wish to comment on. Trevor and then Andrew.
Thank you, Richard. I think for me, this is essential. It's essential because we're also on a different journey, to use that phrase, with the ICS. And actually being clear what our risk appetite is in the context of the conversations we'll need to have in the whole system, I think is vital. Because whilst there will be system risks, where different agencies, whether statutory or non-statutory, sit in those, will be quite different. And so being can improve our sort of management of risk is crucial, but we've got to master that to have the proper conversations in the system.
Thank you, Trevor. Thank you, Trevor. Andrew.
Thanks. Risk appetite came from the financial industry, and really it came down to, if the level of risk in an investment and the likelihood of actually, getting financial loss from that. So some of the read across for me is quite difficult because it's quite abstract. So of course, we've gone with a low risk for patient and a low risk for quality, but we've gone for a high risk for sustainability. But then when we read our definition of a high risk, under sort of systems and partnerships, it talks about, major breakdown in service, legislative compliance, potential risk of injury to staff and patients. And that doesn't feel balanced in terms of we've got no tolerance around the quality and the patient, but on this we have, and there's a direct read across to the impact on patients on that. So I know this is incredibly hard, and I don't have an answer for you, but I just sometimes struggle with the read across from the various risk appetites in different systems.
Thanks, Andrew. I think for me that makes me think about what I mentioned earlier on, which is what's the opportunity here? Risk is two-dimensional. It can be managing adverse potential future events, but it can be actually maximizing opportunity. And I think the world that we're starting to move into in health and social care is probably more about the opportunity. So I think there's work to do in that space that may help balance some of that out. But I take your points absolutely.
I think I would have answered very similarly to Richard. I think when we had the debate last month, wasn't it, Richard, and a genuine debate with voting and conversations, which was a good conversation. I think the issues around systems and partnerships and sustainability was if you're not prepared to take risk, you won't make as much progress as you could. And here was a huge opportunity, particularly in systems and partnerships, but also in sustainability. And the debate actually shifted those risk appetites to the right or to the higher level on the basis that there was a great opportunity here, and in order to take it, you had to take risks. So I take your point. It can be difficult to read across. It can be difficult to get the balance. We haven't particularly done it before, as Richard said. It's a bit of a holy grail for directors of governance and risk. He hasn't found it yet, but we'll sip from it a bit and see how it gets us in the next year or so through some difficult periods. Okay, everybody, thank you very much. This, by the way, the risk appetite was approved by NGH yesterday, so that puts it as agreement as a group. I don't have any questions from the public. I do have 3 items of any other business, which are all mine at the moment. I'll see if there's anybody else's when they come up. The first one is to note that Lisa Llewellyn and Damien's term of office finishes in the not too distant future, and the governor's relevant committee has recommended that they both be renewed for a second term. Congratulations, Lisa and Damien in absentia, and that will be coming to the Council of Governors next week. And they were delighted to recommend your continued appointment, and we're very impressed by the reports you did and the work you did. The second one I have is to thank Anil. This is Anil's last board as the Interim Director of Finance. John will be joining us. John Evans will be joining us from the beginning of June, and John will be sitting on both boards as the Director of Finance for the group. And you all know that there was a requirement to have a Director of Finance on the executive side of all boards. So thank you, Anil. You have done a good job. It's never easy to be an interim, and most people experience sometimes in their lives, and mostly wish they hadn't. So you've done very well, and I'm sure you'll contribute and continue to contribute for a significant time as we beef up the demands placed on our financial functions and the threesome that becomes you, Bola, and John moving forward. And I know we've had lots of conversations about what it might be called further energizing the finance committees in both hospitals with a new chair in Northamptonshire, where Rachel Parker will take over as Chair of Finance and Performance, and Lisa Yanov has agreed to lead some work across the group on opportunities, comparisons, and other things, which I'm sure Lisa could talk about rather more eloquently than I can. But the point is, there's a lot to be done in finance. Thank you for all you've done, and we look forward to further work. And the final one, which is probably arguably going to take ages, is to talk about Andrew Chilton. Hello, Andrew. Andrew predates all of us, not in birth terms, but certainly in joining the board of KGH. He was appointed medical director in May of 2010. That's 11 years ago this month. And he took up the role in August 2010. So he's seen KGH through some significant events, not least of which is 14, at a reasonably conservative estimate, 14 chief executives. Now, that's a pretty damning number in itself, but it's also remarkable praise to Andrew that he's still here and still mostly smiling. When I asked him what emotion he had at the end of his term as a medical director, he said, well, it's a bit like, well, mostly relief, really, because it's a bit like what happens when people stop waterboarding you. And I think what he means by that is more to do with the oversight organizations, the behavior of Monitor all those years ago, and CNST and some of the other organizations predated CQC and some of the ones that were in the early days of CQC. So it hasn't been an easy time when you look back at the history of Kettering over that period. But you know, when you appoint medical directors, well, it's a very, very important appointment for an awful lot of people. And you expect and hope that you don't get a functionary, you get somebody with some real passion for the things that matter to a board, and that's really patient safety and patient-centered care. And when I started in NGH, the thing that I most stopped and said, really, was the patient safety lessons learned forums, where anybody can come, and it's an open and learning conversation. I'd never seen that before. Mostly you come up against all sorts of barriers to that, and professional barriers and specialty barriers and all sorts of things. So the business of patient safety lesson forums and the patient safety advisory group is really quite a remarkable achievement, and they're part of the culture of NGH about how things are talked about far more openly than most other organizations. And you know, if you do start to talk about those things openly, yes, you'll always run into some difficulties, but that culture of not hiding your mistakes, of openly talking about things when they go wrong, is how things get better. We did talk a little bit about Andrew's notable highlights in his term of office, and he chose to talk about the appointment of the two MDs, the deputy medical directors, one of whom is sitting with us. And I think those are also significant appointments. Again, you know, I remember having several conversations with Andrew when he started about all these things he had responsibility for, and they all included things to do, but none of them included people to help him do it. So I think we've moved on a pace there as well. And there's no doubt in the end of the day that the philosophy, which I think I've heard Andrew say on a number of occasions, is that high tide raises all boats. So when you start to raise the quality, collective success is what you're looking for here. We're not looking for a few specialties, we're looking for collective success in right across KGH. So a couple of high spots: Harvard Medical School, talk on innovation, writing the European National Standards for Colonoscopy, honorary chairs at University of Leicester, and I'm sure he's got many other things. And he responded to my comment about HSG awards by saying he's got one in the final for that as well. So, Andrew, you have made a huge difference to KGH. You've pushed hard for new facilities, estate, and you finally, well, we haven't quite seen it yet, but I'm confident we'll see yellow machines digging holes in the ground for the urgent care hub and for the HIP2. And I know as you move on from this job, you're going to be working with Polly. I hesitate to say helping Polly. I suspect it might turn out to be a little bit the other way around. Good luck with that, Polly. But I know you're going to be working on that stuff. So thank you very much for what you've done. You can look back on a lot of achievements, a lot of improvements in patient care, a lot of improvements in culture, a lot fewer doctors are being investigated and a lot fewer issues to be pursued. So thank you very much for all you've done. It's really been a remarkable contribution. I'm going to give you an opportunity to respond to all of that. But I'm going to let Simon go first because I think he's going to say something a little bit similar. Simon.
Thanks, and thanks, Alan. So the first thing I just want to echo your words in respect of Anil. You've done a great job, Anil, steering us through probably one of the most uncertain planning rounds that we've ever faced in the NHS. And both you and Bola have worked really well together and been actually an exemplar of the kind of culture we're trying to create about really working together to achieve different things together. So I just wanted to say thanks. To Andrew, I mean, I was thinking about what to say, and in many respects, I only want to say two things. So the first is, some of us had the occasion to go out and celebrate his stepping down from the role last night. And in sharing some stories of chief executives past, I was reminded of the fact that the voice of stability and continuity throughout all of that has actually been Andrew. And although it may seem a fairly odd thing to highlight, I think stability and continuity is one of the most underrated virtues in the NHS, because it's being there when nobody else is. It's being there when people need somebody to turn to, that is often the invisible but nonetheless pervasive influence that keeps an organisation going. So that was the first thing I wanted to say. And then the second, I suppose, the sincerest tribute I can pay Andrew is in the quality of the team he built. And obviously I have to highlight particularly the two deputy medical directors that I've had the privilege of working with, Manjula, who's recently stepped down, and who I bumped into in the car park yesterday, is looking remarkably well, I have to say. And Rabia, who obviously is sitting here with us today. And perhaps the sincerest tribute I can pay Andrew is we've been able to recruit a successor like Rabia to step into his place. And again, many organisations don't have that capability, and we are fortunate to do that. So I wish him really well. I think I too will watch the Polly-Andrew axis with a great deal of interest. And I'd also like to welcome Rabia to her place at the table. I know she's going to really build on what Andrew has done, as well as bring her own unique style to the job. But today really is about Andrew. Thank you for what you have done. Thank you for all that you have done for people who are, many of whom are not here, who aren't around this table, but who also have cause to thank you a great deal too. Thank you.
Andrew.
Well, thank you, Alan, thank you, Simon, and thank you to all the board. When you said you only had 2 words, I was a little concerned. At that stage, I thought this could be quite direct. So, you know, I woke up, well, just first of all, the whole comparison with waterboarding, it was a bit like being waterboarded at times. And as someone who has been waterboarded, it's not pleasant. I woke up yesterday, the sun was shining, there was a lovely breeze, and, you know, I had a fuzzy feeling and life felt good. And I reflected back on the last 11 years, and they have been challenging, you know, sometimes almost Sisyphusian. And, you know, to quote Sisyphus, it was an eternity of useless effort and unremitting toil. And sometimes it did feel that way. But there were moments of, you know, sublime enjoyment as well during this process where, you know, things went well, you felt you changed things, you felt you made the organization a better place. So it all balances in the end. The different CEOs were very, it was a turbulent time, and it's great to see some stability within the organization, and that stability and that development of the board has been absolutely fantastic. And what I can say, remove the lens of people like CQC, etc. This organization is not the organization I started in. It's just gone from strength to strength to strength. And I think it's a really good organization with great people in it. And it's a really diverse culture out there as well. Some of the things that have happened to me as medical director, we had the first junior doctors strike for many, many years. That in itself was interesting. We've had a pandemic. And we've had multiple turbulent reorganizations within the health service as well. So I'm pleased to be moving on to something that hopefully will see a real bricks and mortar legacy come out of. And that feels like a really positive point. It feels fantastic the way we've just accelerated in our digital naivety towards becoming digitally mature. And that feels really very, very positive. And finally, the last thing to say is really I'm delighted to be able to hand over to Rabia, because Rabia is really excellent and she will make a great colleague to all of you on the board. And so thank you for your support over the years. And just to remind everyone to tread lightly, because we tread on people's lives. Thank you.
Thank you very much, Andrew. Best you can say of anybody is, one, you made a difference, two, you will be missed. Both of those things are true. And in Rabia, you tell me I have to think of you in other ways, but there is no finer person to step into a pair of shoes than Rabia. She's got a lot of them to choose from. So we look forward to you stepping into your own shoes as well as Andrew's. Thank you very much, Rabia and Andrew. Okay, guys, board is asked to approve the resolution that representatives, press and members of the public be excluded from the remainder of the meeting having regard to the confidential nature of the business. Yes, yes, thank you very much indeed. The private meeting is a separate Teams link and it will be 1:30. You have a half an hour break. Thank you very much for all your work this morning.